rheumatic diseases. So it's our honor and privilege to welcome sir, and I welcome him and request him to start his talk now.
I couldn't unmute myself. Apologies. I was trying to find the button. Well, thank you very much for your very nice introduction. This is what I do in life. I'm a physician scientist, exactly as you mentioned it, and what I do is try to search for biomarker and novel targets. This is what we do in our department. However, this is a very clinical, fascinating title. Criteria for early identifications. Let me get to screen mode so that you can see it. Let me invert. You should see it properly now. I hope this is the case. Give me a thumb up if everything is.
Yes,
everything is okay.
You can see it clearly.
Thank you very much. So when we talk about cytokine release syndrome or whatever we want to call it, and we'll get to that in a minute, we actually should go back to the definition of haemato-oncology that was defined by Paul Ehrlich in the early years of the last century, in which he alluded to the fact that the immune system is actually prevented from acting against the organism's own cells. And this was always thought as being the definition of autoimmunity, but this is actually, he talks about autotoxins, which are really the inflammatory cytokines being overproduced. So my interpretation is that he was actually thinking about autoinflammation and hyperinflammation as well. What are we talking about? We all know what autoimmunity is loss of tolerance with the recognition of epitopes of self-antigens, and you need specific antigen receptors to do that. Autoinflammation is slightly different. Autoinflammatory diseases are those diseases that are essentially secondary to activation of innate immune response in the absence of triggers or in the presence of a trivial trigger. Think about cold exposure for cold-induced urticaria, for example. This leads to chronic or recurrent systemic inflammation to tissue damage. We are talking, actually today, we're talking about hyperinflammation, which is an excessive and disproportionate response of the innate and adaptive immunity in response to a reasonable stimulus to do so, viral infection. You discussed a lot dengue yesterday as an infection. This response becomes excessive and therefore kills or leads to damage to the host. And we certainly use autoinflammation and hyperinflammation as umbrella terms that comprises a number of groups of disease, not even a group of diseases, groups of disease. And we have learned, certainly as rheumatologists as I am, that autoinflammation can drift to hyperinflammation. And we know that this is dangerous. This is a typical case. This is a child with active SGIA, typical presentation. If you look at his laboratory features, he has leukocytosis, thrombocytosis, increased acute phase reactant, including fibrinogen, no signs of intravascular coagulation of the coagulation, no organ damage. A little bit of ferritin, but this is pretty usual in autoinflammation, in these forms of autoinflammation. Is standardly treated with glucocorticoids and IL-1 inhibition. However, 2 years later, comes with a different features. He has persistent fever, severe splenomegaly, and the general picture is very severe. And we have learned to see this array of laboratory abnormalities: low white blood cells count, thrombocytopenia, low fibrinogen with signs of intravascular activation of the coagulation, increased tissue damage. This is liver tissue damage here, and ferritin. And we all love ferritin. Now this is, apologies, I forgot to turn on my phone. So this is one of the flavors that we are used to, okay? And it's an easy flavors because we know the patient, we know he's at risk of hyperinflammation, and we can recognize easily the pattern. But this comes into different flavors and unfortunately with different names. We use hyperinflammation, cytokine release syndromes, cytokine storm syndromes, HLHMAS, hyperferritinic sepsis with multiple organ failure, multisystem inflammatory disease in the context of COVID infections, on top of everything else. And it gets really complicated to try to understand and to identify these syndromes with one name, which we don't. So I like to thank, and I'll do it again in the end, a number of people that were convened together with Scott Canna to try to identify early points to consider at the earliest stage of the diagnosis of something that we decided to call HLHMAS. And this is a picture of us and the last time we met in person, which was actually August 2019. And one thing these groups decided was that we didn't want to go into nomenclature. Nomenclature is too complicated. We keep calling these things with different names. We understand these things as different flavors. And in the end, we came up with the decision of calling, for the purpose of this effort and for the manuscript that is going to be finished pretty soon, HLHMAS. We don't want to claim that this is going to be the name. We just decided to use it for this effort. I'm going to use it in my talk. So there is a recognizable pattern, which we have already partly seen. And I like to point out or do here. So the pattern comprises fever, splenomegaly, inappropriately low hemoglobin platelet counts or white blood cells, and this may include neutrophil and or lymphocytes. There is organ dysfunction, typically liver, but there is increase in LDH as well. There is coagulopathy. Increased D-dimers precede low fibrinogens, very often central nervous system dysfunction, and other inflammatory markers, including ferritin. So the do here is that this pattern cannot be evaluated one by one. These parameters have to be evaluated collectively and longitudinally. None of this is specific of anything, as you well know. Ferritin is a key feature. Yes, high ferritin is a key feature. And essentially, all patients with HLHMAS have elevated ferritin. All available criteria for hyperinflammatory syndromes, HLHMAS, whatever you want to call it, include elevated ferritin. But there are different thresholds in different sets of criteria, and ferritin is used in different ways. So this is a very old paper. It's almost 15 years old. It's actually 15 years old. It's consecutive patients admitted to the Texas Children's Hospital in Houston with ferritin values greater than 500. And it's a few hundreds of patients. You know, ferritin above 10,000 was very sensitive and very specific for HLH. The other take-home message is that there is an increase in ferritin. Just look at disease category 1, which is HLH, and at the scale of the y-axis, there is an increase in ferritin levels during HLH disease. So again, pointing to longitudinal evaluation of ferritin. Now, 10,000 is a cutoff that worked in this set of patients. However, I remind you that this is only greater than 500, which is abnormal anyway. So the different cutoffs in this set of samples and in other set of samples leads to different sensitivity and specificity, and it's very difficult to define a cutoff. But the do that I think should be in our mind when we perform early evaluation of HLHMAS is that we do have to measure ferritin, yes. And if we have ongoing suspicion and the patients still have normal or relatively low ferritin, measure serial ferritin, because ferritin changes over time. And this is one of the things that add support to your suspicion. Hemophagocytosis. This will be discussed later in detail, but I'll give you my take. My take is, it's not only my take, it's also the take of the group I showed to you before. So 60% of patients with MAS had hemophagocytosis at the BM aspirates, and these are data from the large 350 patient collection from Francesca Minoi and Angelo Avelli, but 40% did not. And if you look at the diversity of paper in HLH patients fulfilling the 204 criteria, up to 50% of them do not have hemophagocytosis in their first BM aspirates. So if you want to use presence of hemophagocytosis for diagnosis HLH, then you're tossing a coin. You have the same probability of, getting the proper diagnosis as tossing a coin. So my take here is it's a don't. Don't wait for hemophagocytosis to make a diagnosis for HLHMAS. Unfortunately, the first H of HLH stands for hemophagocytic lymphohistiocytosis. So the H there is really wrong. And I think we should think about this in the future because it's misleading. Now, think about the modern ultra-dotted biomarkers if they are available. Here is the list of them, and I'm not going to talk about all of them. I'm going to show you a couple of data on 3 of them, which I think will become more and more useful. So think about them if available. One is IL-18, and the story about IL-18 started when, these 2 back-to-back papers appeared a few years ago on Nature Genetics, showing that essentially a disease characterized by abnormal activation of the NLRC4 inflammasome caused prominent overproduction of interleukin-18. These patients have huge amount of interleukin-18, and they have recurrent episodes of MAS-HLH. And then there is a novel disorder which is due to one specific CDC42 mutation, and this patient, guess what? They have abnormal activation of the NLRC4 inflammasome. I won't go into the mechanism, and very high level of IL-18, and they have recurrent lethal episodes of HLHMAS. And we have progressively learned in these few years that actually IL-18 is a biomarker in SGIA, predisposing to MAS. And I'll show you what is the pathway and why I think we should use IL-18 as a biomarker. It is important, oh yes, it's important. Here is a paper of a patient with an NLRC4 associated disease, the disease I showed to you before, treated with an IL-18 inhibitor, showing resolution of MAS episodes, decrease in ferritin, and possibility to taper essentially all treatment except background canakinumab. And we now have a bispecific antibody, which binds to both IL-1 and IL-18, based on a canakinumab arm and an anti-IL-18 arm, and this is going to be tested in NLRC4 gain-of-function mutation to control the inflammasome-mediated overproduction of both IL-1 and particularly IL-18. Let's go back to mice. So from the future to long time ago. In the perforin deficient mice, which do develop HLH when triggered with the virus, HLH is reversed by interferon gamma neutralization and by CD8 positive cell depletion. Have we learned something regarding biomarker of HLH? I think we have. This is a paper that was published by our group, plus more additional data, showing that actually level of CXCL9 were really significant increase during MAS, but not during active SGIA, and they do reflect interferon gamma production. Here you see the data in MAS and in active SGIA, and you see there is a very tight correlation, increase of CXL9 and a very tight correlation with ferritin levels during active MAS, but not during active systemic GIA. And this is true for CXL9 for the correlation with the number of the typical parameters of the patterns that we have described before, including ALT, LDH, platelet counts, and neutrophil count. Again, showing that CXL9 increase reflects specific abnormalities of the pattern of hyperinflammation. And this has become even more evident when the trial with the anti-interferon gamma antibody was performed in children with primary HLH. You see here is data from 2 patients showing clearly that the decrease in ferritin was paralleled by decrease in CXL9. Again, showing that CXL9 reflects interferon gamma activity, and when you neutralize interferon gamma activity, you get rid of CXL9 and your ferritin decreases, pointing to the importance of interferon gamma in this specific disease. Even more importantly, logistic regression analysis in this trial indicated that the that low CXCL9 levels at the end of treatment were associated with clinical response with the highly significant p-value. I'm sorry, I duplicated the slides. So back to IL-18 and CXCL9. This is a very nice slide from a paper by Scott Canna. You'll hear him tomorrow, I think, who has measured IL-18 and CXCL9. And what you see here is a pattern. In MAS associated with HIA, IL-18 is very high and CXCL9 is increased. In primary HLH, familiar primary HLH, you see that IL-18 is not that high. While it is high in at least part of the infection associated HLH. So you can see a pattern here, a pattern of patients in which IL-18 is very increased here, and a pattern of patients in which IL-18 is not increased. However, CXCL9 is increased all over the board, suggesting that actually IL-18 is important because it does induce interferon gamma production. Let's switch to T cells 1 second. So although Michael Jordan discovered that CD8 positive T cells were important in HLH in 2004, he came up with the biomarker evaluation in vivo in patient only in the middle of last year, in 2021. And this is a very nice paper showing that actually activated CD8 positive T cells expressing HLA-DR and CD38 are really expanded in patients with HLH, and they are able to distinguish early HLH from early sepsis with an area under the curve of 0.92, which is almost perfect. In our laboratory, Juicy, together with Ariana in the clinics, decided to look at SGIA, MAS in SGIA, and other secondary forms of HLH. And again, you can see the same population is present in this secondary form of HLH, and the area under the curve to distinguish from active SGIA, from autoinflammation, it's again almost perfect, and it's almost ideal. And we also identified a new population of CD3 positive cells that express CD8, that are CD8 positive and have low level of CD4 deemed CD8 positive T cells. These are very high in patients with MAS, several forms of secondary HLH, and appear to distinguish as well as. So this is very trivial flow cytometry that almost anybody can do. So I think we should think about these three biomarkers, IL-18 associated with autoinflammations and high-level predisposes to HLHMAS. CXCL9 is associated with HLHMAS and reflects interferon gamma overproduction. And CD8 activated T cell populations, particularly CD4 DIM and the CD38 HLA-DR positive cells, appear to be useful in a clinical setting to identify patients with HLHMAS. Now, besides the biomarker, we still use our diagnostic classification criteria. There are several sets. There are 3 sets of criteria that I'd like to point out to you. They perform well in the settings in which they were generated. They tend to identify the pattern, the recognizable pattern we have talked before, but they perform well in a given setting, the setting they were generated from. Okay, so this is SGIA-MAS, this is adults with cancer and HLH secondary to malignancy, and this is primary and secondary HLH, but mostly monogenic HLH. Let me get into one little piece of detail. And this is from the MAS criteria in SGIA, and I'm sure you know them. So platelet threshold and fibrinogen threshold are well within normal limits. So you don't have to wait for profound cytopenia or profound coagulopathy to think about MAS HLH. You just have to think that these things are inappropriately low. You would expect thrombocytosis, not borderline low platelet counts in this patient. And in the data set that was used to generate that criteria, we had a consensus meeting altogether in which we looked at change over time. And it was pretty clear that it was a change over time of these 3 things that were considered most important for the diagnosis of MAS in this context. So changes over time are important. So my take-home message here is no single set of criteria is sufficient to diagnose HLHMAS across all contexts. Trends over time are more relevant than absolute values. And the don't is do not apply strict to the criteria. Just don't go with the criteria, snatched on the door of your ICU of your ICU. Think about the trends over time and not the absolute value. The last message concerns underlying and predisposing condition. Now, this is a mess, to tell you the truth. There is a very large group of underlying or predisposing conditions that are associated with HLHMAS, and they include a lot of stuff: infections, rheumatic diseases, malignancies, metabolic diseases, genetic inborn error of immunity, and more than that. This is a rather old classification of HLH, but it gives you a message. The genetic forms are really rare. They may get to 5%. I don't think we get to 10%. I think they're below 5%. Okay, and everything else is everything else. And you have to look for secondary HLH or acquired HLH. And this is a major issue when you are dealing with a patient with early suspicion of HLH. Let me get a little bit into a couple of examples. Let's assume you have a patient with early HLHMAS, and you think that there is an underlying inborn error of immunity that has to do with cytotoxicity, as you know. So you have to perform cytotoxic functional test and genetics testing. You have to do, yes, you have to do it early, because identification of a monogenic HLHMAS dramatically affects management. You have to use the better available approach, which is etoposide, which is not really used in all the other sets of HLHMAS. The early, the better. The early, the better you start to look for a bone marrow donor, because this is the only curative treatment so far. So this is something you have to start thinking early, even if it is rare, but you have to start thinking early. I'll make the other example regarding infections. Now, infection, the list of infections that have been associated with HLHMAS is huge. It will need 10 slides, and you won't be able to read the slides because the font will be too small. The other take-home message here is that frequency of each infection depends on local prevalence and on genetic background of the populations. However, immediate treatment of the underlying infection may be all that is needed to stabilize the patient. You may not even have to use immunomodulatory treatment. Think about leishmania. So what I'm trying to convey here is do early evaluation for underlying predisposing condition and postpone treatment if possible until diagnostic testing for underlying condition is concluded. So, and here you are in between. It's not an easy situation. Most often you have to use common sense. And there are no data to guide you here. But I think these are two good principles to be used. And finally, early stabilization and treatment I alluded to. Some of these patients are acutely sick and they worsen very rapidly. Sometimes it's a matter of not even a day, it's a matter of a few hours. They can, almost die overnight. And so there are one do and one don't. Try not to use glucocorticoids before having excluded malignancy. This is particularly important in adults. Malignancies are very rarely associated with HLHMAS in children. Try not to use them because they will mess up with your ability to diagnose a malignancy. When you want to stabilize a patient, high-dose glucocorticoids are your best drug, okay? But they will interfere with some of your differentials. Anakinra and or IVIG won't. So I think these three should be considered. And this is as far as I will go. Can't get into more detail, also for the sake of time. I would like to thank you for your attention. I would like to thank the people that work in our group in Rome, both the clinical people, Claudia, you will meet her right after me, and the laboratory people, particularly Giusy and Valentina and Ivan, that are pivotal in running the HLHMAS studies that I've shown to you. I would like again to thank the group of people. This is Scott Canna, you'll meet him tomorrow, Rebecca, Angelo Ravelli, and many other people that you probably know by face. Thank you very much for the attention. I'll take any questions.
Thank you, Dr. Benedetti, for a wonderful lecture on do's and don'ts in a cytokine release syndrome. There are a couple of questions in the chat box. The first question by Dr. Kausalya is, how long after the fever starts would the ferritin touch that 10,000 levels? So do we need to keep monitoring them serially because the ferritin is not high enough?
I think again is the trend. You don't need to achieve 10,000 to have a strong suspicion or even a diagnosis of HLH. It's the trend over time, and there is no time cutoff here. Some patients stay there for a while, and all of a sudden they get worse. Okay, it's the pattern, but ferritin must be part of the pattern and has to be tested longitudinally. I'm sorry, no rule here. Just clinical common sense.
True.
This is unfortunately not that common.
Well, it's unfortunately and fortunately, if I may say so, because it's the beauty of our job.
Absolutely.
Sometimes we get dengue patients with a ferritin of 30,000, 40,000. But if they're clinically stable and the fever is settling down, other parameters are settling down, we just wait and watch. And after maybe 24, 48 hours, the ferritin will start reducing. I had one question, sir. Do you use procalcitonin level also as one of the markers for cytokine release syndrome?
I mean, in some patients, it is increased. We have seen some patients with, let's call autoinflammatory, triggered or associated HLHMAS with high procalcitonin, but it's not generally the rule. And therefore, I think I don't think we have enough data. I don't have enough data. I don't think we have enough data.
There are a couple of other questions. Dr. Madhumati has this comment to make. If hemophagocytosis is like a toss of a coin in a macrophage activation syndrome or a HLH, shouldn't we change that? Wouldn't mass be a superior term to use? I think you would agree as a rheumatologist, isn't it?
No, I wouldn't. It's forbidden. Don't talk about nomenclature here. No, but I think again common sense. Don't wait for the first H to appear. Okay. That's wrong. We don't need it. We'll discuss it. But I think my easy take-home message is that we don't need it. It's confirmatory. Yes. The reason why you do your bone marrow aspirates as soon as possible is because you want to exclude malignancy. This is one of the ways to exclude malignancy. So yes, you do it, but you don't look for hemophagocytosis. Look for something else. If you find it, you get nice pictures.
Sir, how about monitoring anti-inflammatory cytokines like IL-10?
Those are all difficult questions. No, I don't think you should. I think it's increased. It's going to be increased, market increased, because the system is trying to pump up the anti-inflammatory pathways as much as it can, because the system understands that there is too much inflammation. So sepsis is very high level of IL-10.
Yes.
Is it helpful? Is it good or bad? Talking about diagnosis, I think it's not useful.
Okay.
There is one interesting question. Should we consider screening children with HLHMAS for familial HLH? If not for all, but at least for a few, and who would be those whom you would screen for HLH?
For familial HLH?
In the systemic onset GIA, whom would you screen? Would you screen anybody for a familial HLH, like perforin, MUNC, or associated genes, or you wouldn't?
Why don't you ask this question to Claudia Bracaglia? This is what she's going to talk about, and she has the data more at hand than me. But I would not. I would not. But I'll tell you a very brief anecdote. We had a patient presenting with fever, rash, tenosynovitis of the wrist, polyarticular involvement, high fever, rash, splenomegaly, MAS. So this is SGIA with MAS. Well, now it turned out that the patient was lymphopenic, a little bit too much, and lymphopenia persisted. When it got better, it was pretty clear that he was very young, he had less than 1 year. It's pretty clear something was wrong with his CNS. And it turned out that he had PNP, purine nucleotide deficiency. phosphorylase deficiency, which is actually associated with an immune defect, and it's an inborn error of metabolism. So do we screen them all? No, well, we pay attention for things that do not fit the pattern of SGIA and MAS.
Okay. Particularly if the age is less than 2 years, consanguineous marriage.
Sorry, I missed, there was a breakage in the connection.
Is if the age is less than 2 years of age or consanguineous marriage, then you will think more.
Yeah, this is one of the things that is out of context. Yes.
Dr. Fabrizio, thank you very much for answering.
My pleasure.
And there are 2 questions in the chat box. Whenever you have time, if you can just kindly answer. For the want of time, I'll be going to the next speaker. Thank you so much for spending your afternoon with us, Dr. Fabrizio. So it is an honor to introduce Dr. Claudia Bracaglia. I hope I am spelling the second name right, because G is silent in Italian, as I realize. Is that right, Dr. Claudia?
Yes, it is. It's correct. Perfect.
Spending 6 months in Italy does help. She wears 2 hats, and I'm really envious of the fact that she is both a clinician and is also involved in translational research. She comes with the same pedigree as Dr. Fabrizio Benedetti, and she is trained in Bambino Gesù Children's Hospital, Rome, and she is a true person from Rome. And she spent some time with Professor Rob Sundell. And last 12 to 13 years, she has been a full-time faculty at Bambino Gesù Children's Hospital in Rome. And she, I think, loves systemic onset GIA. She's been associated with interstitial lung disease associated with SGIA. And she is the chair of macrophage activation syndrome, SGIA working party of PRESS. The stage is yours, Claudia. Wonderful to have you here.
Thank you. Thank you very much for your kind presentation. Okay. So I'm going to talk about the genetics of acquired cytokine storm syndrome today. Yeah, my disclosure. So in the family of the family of cytokine storm syndrome is quite huge. So under the umbrella of the cytokine storm syndrome, there are included some different conditions that presented similar clinical manifestation, laboratory features, but with completely different triggers. And one of these is, of course, HLH. So in the spectrum of HLH, we have on one side the primary or familial form, in which the genetic defect in the cytotoxic pathway causes the activation of T cells and the monocyte, and that is responsible of clinical manifestation. And on the other hand, we have the secondary or reactive or non-familial forms, in which the genetic background is not known and also can be triggered by different conditions such as infection, rheumatic disorders, and part of them are also triggered by unknown trigger. But nevertheless, both form, primary and secondary, this very similar phenotype and are a unique clinical syndrome. So in normal condition, CD8 positive T cells and NK cells leads to target cells when the cells, for example, is infected by a virus, and also produce interferon gamma that stimulates the macrophage production that helps the NK cells in this process of phagocytosis. But in familial HLH, the mutation of genes that are involved in cytotoxic activity stop this mechanism, and the CD8 positive T cells cannot lyse the target cells. So this causes a proliferation and hyperactivation CD8 positive T cells and NK cells that produce a large amount of interferon gamma. The interferon gamma stimulates the hyperactivation and proliferation of macrophages, and these macrophages in part help the NK cells to phagocyte the infected cells, but they also produce a large amount of inflammatory cytokine that are responsible of the cytokine storm, that is the cause of clinical and laboratory manifestation of HLH. So in familial HLH, the cytotoxic mechanism can be impaired at different level. It depends on which genes is involved in the disease. And so here the list of genes that are usually involved in monogenic HLH. So the first genes are involved in the familial form of HLH, but we have also some genes that are involved in different form of HLH or recurrent HLH related to inflammasome activation. As Dr. De Benedetti already said, the frequency of these primary forms is very low, is under 10% compared to the secondary form that can be caused by different triggers, particularly by infections such as EBV, leishmania, and influenza, or malignancies like lymphoma, particularly T cells lymphoma, and also leukemia, and rheumatic disorders. These forms are those forms that, as rheumatologists, we call MAS, that can be caused in premise by systemic JA, but also by systemic lupus, vasculitis, or Kawasaki disease. And we have a quite big percentage of this disease, of this form of secondary HLH, in which the trigger cannot be found. So in the pathogenic mechanism of MAS and secondary HLH, the genetic predisposition, the genetic contribution is quite important and can be a different way depending on the form. So in the primary forms, the genetic defect in cytotoxic pathway can directly activate the T cell activation and proliferation and expansion, and can be directly responsible of the cytokine storms. But in some condition, there is a genetic predisposition to macrophages activation, and these forms are two diseases that Dr. De Benedetti already presented, particularly the NLRP4 disease. This condition is an autoinflammatory condition characterized by early onset fever, rash, diarrhea, splenomegaly, and recurrent mass HLH. So this patient produce a large amount of interleukin-1 beta and IL-18, but they also produce CXCL9, that is a biomarker directly produced by interferon gamma. And the disease related to a defect in CDC42 is a very similar condition characterized by early onset cytopenia without inflammation and HLH. And also these patients are typically characterized by recurrent HLH and have high levels of IL-1 beta, IL-18, and also CXCL9. So in this pathogenic mechanism, the genetic background can be a very relevant role. But we know that the genetic background is important also in MAS in the context of systemic JA. So there are a number of studies of reports on the presence of heterozygous missense mutation in perforin-1 in patients with systemic JA complicated by MAS, particularly in European cohort. And the most common missense mutation in this population is the A91V that have a dominant negative effects on the lymphocyte cytolytic function. And also defect in UNC13D and polymorphism in this gene were represented in patients with systemic JA complicated by MAS, and this was reported particularly in North American patients. And heterozygous mutation in both gene, perforin-1 and UNC13D, are believed to contribute to decrease the NK cell function. And effective NK activity and perforin expression have been described in patients with this systemic JA and MAS. And also mutation in other gene of familial HLH have been observed also in patients with MAS and secondary HLH. So variants in LIS, syntacin binding protein 2, syntacin 11, and RAB27A. So number of patients with systemic JA and familial and MAS presented variants in these genes. But the genetic background is also important in other form of HLH. So in this report, Dr. Schulert collected data from patients with HLH secondary to influenza, so patients who died with HLH during the pandemic of 2009, and 36% of these patients presented an heterozygous missense mutation in LIST. And also 2 out of 5 patients who died presented also a variant in perforin-1 gene. So the genetic predisposition can have a relevant role not only in MAS in the context of systemic JAA, but also in HLH secondary to other triggers. So I would like to tell you the story of two of our patients. So this is the history of Riccardo, a patient who presented at us when he was 12 years old with persistent fever, diarrhea, vomiting, and rash, hepatosplenomegaly, and arthritis. His lab presented an leukocytosis with a mild increase, with an increase in transaminase and LDH, and also an increase in the dimers, CRP, and ferritin. The bone marrow biopsy showed an activated macrophages with evidence of hemophagocytosis. So he started immediately immunosuppressive treatment with cyclosporine and methylprednisolone, followed by oral prednisone. But actually, his laboratory parameters did not improve, and ferritin going up, and also the transaminases. So he need treatment with high immunosuppressive drug. He was treated with a weekly intravenous cyclophosphamide and dexamethasone with a progressive improvement. So he was fine for around 4 years, completely free from his disease, but then he came back to us with a persistent fever, rash again, and arthralgia and myalgia. And laboratory parameters show a normal white blood count and also platelet count, and transaminases started to increase a little bit, and then also CRP and ferritin presented a progressive increasing. The bone marrow biopsy confirmed also this time the presence of activated macrophages and evidence of hemophagocytosis. So he started immediately dexamethasone and cyclosporine with progressive clinical improvement. But this time we performed a genetic analysis and we found a single copy missense mutation in RAB27A. And the same mutation was found also in his father, that he was apparently healthy, but he had a history of high ferritin levels during his life. So we put this patient together with another patient with the same variants, followed by Dr. Randy Gron, and he went to in the lab to study the cytotoxic activity, the functional tests in this patient, both patients. And in our patient, we found a decreased degranulation, decreased NK cytotoxicity. And this was demonstrated by the presence of inflammation that induced decrease in perforin expression. So the presence of IL-6 with the cells of the patient demonstrated a decrease in perforin expression. So Mauro is another patient following our center that we know when he was very young, and when he was 3 years old, he presented with systemic JA onset with first episode of MAS. During this clinical history, he presented 3 additional episodes of MAS. The last of this episode required an admission in ICU. He had SNS involvement. So he was treated with high-dose glucocorticoids, cyclosporine A, and etoposide, and also he required tocilizumab to control the systemic JAA. So here the 3 episodes of MAS, as you can see, the platelet, white blood count, and ferritin during the 3 episodes, and also the cytokine level during the 3 episodes of MAS. So we performed the genetic analysis also in Mauro, and we found that he carries 2 variants in 2 different HLH genes, the syntacin 11 gene and the syntacin binding protein gene. And he presented also a transient defect in NK cytotoxic activity. So as you can see in this graph, the patient had a very low cytotoxic activity during an MAS episode that recovered a little bit after 1 month after the MAS, but remain lower compared to healthy controls. So now we know why this has happened, because from our lab, through this mice model of IL-6 transgenic mice, we know that the transition NK defect can be caused by IL-6 production. So as you can see here, wild-type mice and IL-6 transgenic mice had a normal, a low NK activity. But when we stimulate isolate the mice with a poly-CI that can mimic a viral infection, we have an increase of NK activity in wild-type mice, but the activity was low in IL-6 transgenic mice. So this explains the role of IL-6 levels in reduce the NK response, the NK activity in these mice models, and this is very important in our patients. So together with the genetic background, the genetic predisposition, the inflammatory background is very relevant to activate the patient and to move the patient through the onset of the disease and to activate the cytokine storm to present the HLH. So we also analyzed the familial HLH genes in our cohort of patients with MAS and secondary HLH. So we decide to evaluate the presence of variants of genes related to primary HLH in our cohort of patients, and we would like to evaluate the frequency of variants and the correlation with clinical characteristics. So with the next generation sequencing, we analyze the panel with HLH genes, and we analyzed 125 patients. 47 patients in our cohort had MAS in the context of different rheumatic disease, 39 in the context of systemic GIA, and 8 in the context of other rheumatic disease. And we had also 32 patients with HLH secondary to infection or without any identifiable trigger. 22 patients had systemic GIA without MAS, and we also analyzed 24 patients without inflammatory disease. So here the distribution of variant in our population, as you can see, the patient without inflammatory disease had lower variants compared to the other group of patients, but the difference was not significant compared to MAS and secondary HLH, but was significant when we compare autoinflammatory disease and secondary HLH. So here the patient with more than one variant, so again, patient without inflammatory disease and had less variants compared to the other groups, but the difference was not significant. So here the variants in the different genes. So as you can see, in the different group of patients, the distribution of genes carrying variants was almost similar. We didn't find any relevant differences. We then look in particular to SGIA patients. We divided our group of patients in SGIA with or without MAS, and actually we did not find any difference comparing patient without variants and patient with one or more than one variants. And we then look at the correlation with clinical manifestation, particularly with disease severity and recurrence. So we look with relapse disease, CNS involvement, ICU admission, and death. And actually, looking at the mass group of patients, we did not find any differences between patients who carry no variants or more than one variants. And the difference was not significant for any manifestation. And the same was for HLH. So again, we didn't find any differences between patients who did not carry any variants compared to patients that have more than one variant. But actually, if you look at the number, well, we found that patients with more than one variant presented more relapses of disease and more severe disease with more admission in ICU, even if this correlation is not significant. And so this is expected if we look at the mice model that Sepulveda reported some years ago, because it demonstrated that mice carrying heterozygous mutation in more than one primary HLH gene had a higher risk to develop HLH after a viral infection. This suggests that an accumulation of partial genetic defects may be very relevant for HLH. And there are also some data reported in patients with similar results. Moreover, looking at the data that the group of Randy Cron reported in patients with secondary HLH that demonstrate that the patient with variant in syntaxine binding protein had fatal outcomes, and we look at the variants also in our patient. And actually, we did not find any correlation between the presence of variants and survival in the MAS group, because as you can see, the only patient who died didn't carry any variants. And the same was the secondary HLH. We did not find any significant correlation between the variants and the survival. So in conclusion, data on genetics in secondary HLH are not conclusive. So the genetics plays a relevant role in the pathogenesis of secondary HLH, and the involved genes are many, but patients are few, because we need to divide them in different groups depending on the trigger. And it is like that different triggers may have a different genetic background. So I would like to tell you that we need still a long way to go to better understand the real role of genetic in the pathogenesis of HLH. And I would like to conclude to announce the first press academic course on systemic GI and MAS that will be on March in Rome. The course will be hybrid, so you can join also virtually, and we are very glad to host you. And I would like to thank you for your attention, and then I open for your question. Thank you.
Thank you so much, Claudia, for a wonderful talk on eye-opener actually for combination of systemic onset GI and macrophage activation syndrome. So if the same question which I asked Fabrizio, now if you have a patient with a systemic onset juvenile idiopathic arthritis and he has repeated macrophage activation syndrome, I'm reaffirming the question which has been asked by Dr. Narendra. So would you do a genetic testing in such a patient? Would it be helpful proving that there is a genetic fault? And if so, how?
Yeah, so actually I do not do routinely the genetic analysis of HLA genes in patients with systemic GI and MAS, but if we have a patient very difficult with recurrent episodes, I would like to suggest to analyze the HLA gene to see if there is variants that can contribute genetically to the recurrence of the disease.
Okay. And if we find a variant of significance in such a patient, question whether a bone marrow transplantation in such a patient will be useful to prevent repeated episodes of macrophage activation syndrome.
Yeah, so actually I don't have an experience in this but yes, it could be an option. I would like to take in account the possibility, the opportunity to transplant a patient with variants, one or more than one variants that can recurrent MAS episode, dependent on the quality of life of patient. If the patient has very frequent recurrent episode, and if you need a very high immunosuppressive treatment, so the transplant could be an option. I mean.
Okay. And if you have a patient with a macrophage activation syndrome, and we have done the genetic testing, and we find there are no suggestive genetic defects which can explain it, is it that there are some more genes which we are not aware might be causing the disease?
Sorry, I don't understand well your question. Sorry.
Now, if we have a child with a repeated macrophage activation syndrome, and we do a genetic analysis, and we don't find a gene at fault, which is supposed to be associated with a macrophage activation syndrome. So how do we proceed further? Do we need to send to a research laboratory like NIH or to Rome for the analysis?
Yeah, I mean, so probably we don't know all the genes that are involved in HLH. So it is possible that we can find the variants responsible if there is one. If I have a patient with a recurrent MAS and the genetic analysis, at least for the primary HLH genes, is negative, I would like to go through a vulexome or a more extended genetic analysis. Yeah.
Sure. Thank you so much, Claudia, for a wonderful talk. It is a pleasure having you with us. So we'll be going on to our next session.
Thank you very much.
So much, Claudia. Thank you. So to discuss about is marrow hemophagocytosis necessary for diagnosis of cytokine release syndrome, we have two eminent faculty with us. The first speaker would be Dr. Satish Kumar. I don't think the Indian audience needs much introduction to him, but it's still my duty to introduce him. He is the professor of pediatrics at CMC Vellore. He's been trained at Sick Kids Toronto, and he founded the Pediatric Rheumatology Services with Dr. Devashish Danda and CMC Vellore, and he has more than 95 publications. I would request Dr. Satish to take the stage, please. Thank you.
Yeah, thank you. Thank you, Dr. Anand, for kind introduction. And I want to thank Dr. Chandrika for inviting me to deliver this talk. Is my slides are on the...
It's
Yes.
not full screen, sir.
Yeah, now it's full screen?
No, not yet.
Okay, I will just... okay, I will... Is it now? Yeah.
It's not. Yes.
Yeah. It is.
Yes, it is. Okay. Thank you, Chandrika. So the topic given to me was talk about predictive value of bone marrow hemophagocytosis and cytokine release syndrome. So this is my perspective. How good is it, hemophagocytosis, bone marrow, to diagnose cytokine release syndrome? So already much is talked about yesterday by Dr. Ramanan, today by Dr. Fabricio has spoken so much about marrow hemophagocytosis. So I'm going to tell my perspective in the next 10 minutes. So I'll start with the case child, which we have seen last month. So this child I'm following for a long time. So this child I'm seeing initially when the child is around 2 years of age. This child presented with a classical fever, classical rash, and arthritis typical of systemic JA. So this child was started treatment on prednisolone and methotrexate. Prednisolone was tapered and stopped and continued on methotrexate. The child was doing well, and when the child is around 5 years, she had a severe systemic flare. So this child has received tocilizumab injection for 6 doses. Disease was put under control, was continued on methotrexate. This child was admitted again with pneumonia last year, needing IV antibiotics, and got settled. So this time on January 21st, this child came to us with fever for 3 weeks, worsening of the arthritis, and this time the rash is not predominant. So this child is already on 10 milligram of methotrexate now and prednisolone 5 mg once a day. So on examination, this child was febrile, had a little bit of high heart rate, BPs were in the borderline, but was saturating in the room air, has got hepatosplenomegaly, and this child has got arthritis involving elbows, knees, and ankle. So the clinical diagnosis, as any child with systemic JA, comes with fever and worsening of arthritis. We think of disease flare. Because the child is immunocompromised for the last 4 years, which we considered sepsis. And again, we considered MAS, which is called secondary HLH or cytokine release syndrome. So the investigations, what we did on the time of admission, showed anemia, white cell counts of 13,000, which are absolutely normal. Platelets were 2,80,000. ESR is slightly raised, CRP is very high, and liver functions and renal functions are normal, chest X-ray is normal, and blood culture was done and started on antibiotics. And as we consider MAS bar HLH, so this child fibrinogen was low, ferritin was 43,000, and triglycerides were slightly elevated. So what will you do? Will you do a bone marrow for hemophagocytosis to compare, to confirm the diagnosis of HLH or MAS in this child? Or what will you do in your day-to-day practice? So we are talking so much, Dr. Fabricio has talked about HLH, MAS. Nowadays, we are talking about cytokine release syndrome. So this is, I think most of you able to make out. This is Dr. Ramanan in 2003 when he was doing his fellowship in Sickitts Hospital. He wrote an editorial along with Dr. Schneider about the macrophage activation syndrome. That's a time when rheumatologists started to think about macrophage activation syndromes. He said, what is the name? You call HLH or MAS. That time itself, in that paper in 2003 in Journal of Rheumatology, he said that to realize that failure to demonstrate hemophagocytosis does not negate the diagnosis of HLH. And that time itself, they had a plan to do consensus guidelines for diagnosis of MAS, and then it should be validated also. And they said that MAS should be considered as a secondary HLH disorder and should be recognized much. This is the time when I was getting trained there in Sickitts. We started to read more about what is called macrophage activation syndrome. So now in 2020, after the COVID has come, the name is slightly changed to cytokine release syndrome. This picture is already shown by so many speakers. So it is not a one disease. It is comprised of different things which lead to the final outcome. So what I say, HLH, MAS, cytokine release syndrome is not the primary diagnosis. It is a final outcome of some disease, which could be, previous talk we heard about genetic mutation. It can be due to immune dysregulation. It can be due to a lot of autoimmune disease, which rheumatologists deal with, and malignancy and lymphoma. And here you can see a lot of infections can also lead to HLH. HLH getting worse and worse lead to cytokine storm. And finally, it lead to multi-organ dysfunction. That's the time when they land up with ICU. So when you look into the pathogenesis, so when you say cytokine storm syndrome, in the children with hemophagocytic syndrome, when they become life-threatening hyperinflammatory condition, as I said, it can be due to mutations or it can be due to inflammatory conditions, overactivation of macrophages, leading to hypersecretion of several cytokines, pro-inflammatory cytokines like IL-1, 2, 6, 12, 16, leading to cytokine storm, again stimulating the macrophages, leading to hemophagocytosis, which lead to a typical clinical manifestations. Okay, so Dr. Fabricio already spoken about this criteria. Dr. Hunter yesterday spoke about this criteria. We all know that this is for primary HLH. So we cannot come with this criteria. This criteria is mainly for the primary HLH. Again, in that, we have the hemophagocytosis on the liver, bone marrow, liver, spleen, or lymph nodes. Again, remember, it's very difficult to get. It's not easily available. Like it's not readily, the results will not be readily available, and the child may be sick. And it is modified in 2009. There are also hemophagocytosis there in the criteria, one of the criteria. So it is not like a mandatory criteria to diagnose somebody to have primary HLH. Then these are the 4 different criteria which Dr. Fabricio already spoke about. So we talked about the familial HLH 2004 criteria for primary HLH. In that, hemophagocytosis is there. So if you have 5 out of 8, sensitivity is 100% and specificity is 80%. Then this HS score, which is mainly done in adults. It is not done in pediatrics. It is to differentiate again primary HLH versus macrophage activation syndrome. Again, they're given points to each and every criteria. So what they said is here we can see the hemophagocytosis bone marrow. The score, if it is more than 169, the sensitivity of 93% and specificity of 86%. The other 2 criteria are this MH score, where we don't have hemophagocytosis in the criteria. And recently in 2016, Dr. Fabricio talked about this systemic JA. In children with systemic JA, when you suspect mass, there also we don't have the hemophagocytosis as a criteria. So if anybody who has got ferritin in a child with systemic JA, the ferritin is more than 684 plus 2 parameters, either the platelets or the liver parameter, liver SGOT, SGPT, then we can call them as MAS. So when I looked back to the literature, how good is this hemophagocytosis in the bone marrow? So there are a lot of studies, from old studies to recent studies, which showed that the bone marrow hemophagocytosis, the sensitivity and the specificity is very low. The various studies showed, in this study, they showed that hemophagocytosis sensitivity is 83% and specificity is only 60%. They also said that bone marrow findings of hemophagocytosis should not play a role in the diagnosis of HLH or MAS. They also said that we should go for other biomarkers and then waiting for this bone marrow hemophagocytosis to come. There is a recent paper which is published in 2020 in Critical Care. So they looked at how good is two criteria, HLH 2004 criteria and HS score. Again, this is done in the adult ICU setup. What they found out, you can see that hemophagocytosis, the sensitivity specificity is very, very low. So we cannot rely on bone marrow hemophagocytosis alone for diagnosis of HLH. As Dr. Fabricio said, 50% chance. You flip a coin, if you get it, yes. If it's not get it, does not mean the patient does not have HLH. So in the earlier days, it was given so much importance. I think there are a lot of new biomarkers, which Dr. Fabricio already spoken about in 2022. So you can see here, these are the newer biomarkers, which can be used in the assessing the status of hyperinflammation. And Dr. Fabricio already spoke about IL-18. Very high levels indicate MAS, but not useful for monitoring. He already talked about CXCL9, elevated in most cases of cytokine storm, and it is useful for monitoring. And IL-2RA, CD25, this is their part of the criteria. And very commonly available biomarkers like your CRP, ferritin, very, very important, procalcitonin, ferritin ESR ratio, all can be used for as a biomarker for cytokine release syndrome. So does we do bone marrow again to look whether the hemophagocytosis is gone? So it's very difficult to do, and there is no data to support that. At the follow-up also, I will do bone marrow or other tissue to look for hemophagocytosis. So to summarize, so what I have said so far, the diagnostic performance of hemophagocytosis, it is not sensitive. Often it can be absent initially. Sometimes you may have to keep on doing bone marrow to pick up this hemophagocytosis. Sensitivity may be a range of 50%. Repeat biopsy later may show. Again, yesterday we are talking about this hemophagocytosis can be seen in other infections, even small viral infection. We can have 1 or 2% of hemophagocytosis bone marrow. It can lead to blood transfusions and other autoimmune diseases. So what we do routinely, usually most of the time, children with CRS, the cytokine release syndrome, are sick with bleeding, with liver dysfunction. So bone marrow cannot be done to look for hemophagocytosis. So most of the time we use ferritin as a marker for cytokine release syndrome. This is a picture which Ramanan showed yesterday. If any ferritin more than 10,000, think of HLHMAS or cytokine release syndrome, and then do all the other investigations to confirm. So what happened to our child? I told him our child had ferritin of 43,000. This child was started on methylprednisolone, 2 milligram per kilogram, because the child is in the ward, not very sick, not in shock, no liver dysfunction. I started 2 milligram. After 2 days, the ferritin started to come down, but the platelets are still dropping, white cell counts are still dropping. So I added cyclosporine. Following methylprednisolone 2 milligram and cyclosporine, the child started to improve, and the child got discharged on orals, cyclosporine, and steroids. So what is the take-home message? Summarize: cytokine storm is the outcome rather than the final diagnosis. There is no specific criteria for diagnosis of secondary HLS or CRS. Timely diagnosis of HLS is of particular importance. Go by the case by case and use your resources of test correctly. Hemophagocytosis has got very low sensitivity in the diagnosis of CRS. Simple biomarkers of ferritin, CRP, low, ESR, and fibrin useful. And again, the last thing is, don't wait to demonstrate hemophagocytosis, and you should start treatment at the most. Thank you very much for this opportunity.
Satish, thank you for a wonderful talk. Before we go to the next speaker, Dr. Randy Cron has a comment to make that bone marrow analysis is not only used for hemophagocytosis, but can also be used to diagnose leukemia and
yes,
few certain infections when we do a bone marrow culture.
Yeah, more than excluding, not for diagnosing, more for excluding the other causes. Agree. Yeah.
To get the other perspective, the hematologist perspective, which these are the people who do the bone marrow examination. We have Dr. Anand Prakash, and it's my proud privilege to introduce Anand Prakash, whom I've known for the last 1.5 decades. When he was a postgraduate student, then he was a colleague of mine in St. John's. Then he went on to do his fellowship in Hemonc in Gangaram Hospital, and he also pursued fellowship in Paediatric Hemonc in Sick Kids, Toronto. And he'll be giving us the haemato-oncological profile, perspective about is bone marrow hemophagocytosis required for diagnosis. Anand, stage is yours. Thank you.
Thanks so much, Dr. Anand, for that kind introduction. I hope my slides are seen on full screen.
Yes, they are.
Okay, thanks so much. Thanks to the team from Rainbow, Dr. Chandrika, Dr. Rakshay. It's been a wonderful learning opportunity. And I think this is one of the few meetings where we've had specialists from intensive care and rheumatology to actually discuss these challenging diagnoses. Let me give you, like Anand said, the pediatric hemonc doctor's perspective, because I think the hemonc team is getting a little, into trouble, because it looks like the rheumatologists and the intensive care teams are very worried. These hemonc people come in, they ask for marrows, they delay diagnosis. And so the question which was put to me is marrow hemophagocytosis necessary for the diagnosis of CRS? And clearly, I think across the board, we will all agree that marrow hemophagocytosis is not necessary for the diagnosis of CRS. But clearly, just like in research, the right question has to be asked. In clinical medicine also, the right test and the right question has to be asked. So if we change the question to, is a bone marrow useful in a patient with suspected HLH? Then I think across the board, we will all say yes, maybe. And if we change the question a little further and say that is a bone marrow mandatory in certain clinical settings of MAS, HLH, CRS, where the diagnosis is still not clear, I think you'll all agree with me that yes, definitely in some cases, marrows definitely are helpful. So I'll take you over the next 10 minutes to look at some of the challenging pediatric hemonc scenarios, the challenges we all face prior to the diagnosis. Once you know, like in Dr. Satish's case, that yes, this is a patient with SLE and they've evolved to MAS, things are kind of straightforward. But when there is a new patient, what are the challenges that a pediatric hemonc doctor faces? And settings where I'll defend my hemonc teams, where they actually ask for a marrow examination. So I think Dr. Fabrizio has warned us that we shouldn't talk about names, and I won't labor on the name game in this presentation. But I think if, like the old Indian fable of the blind men touching the elephant at different parts, if we all open our blinds and speak to each other, we would get the right diagnosis. So CRS is a common pathophysiological pathway, and the hemonc person looks at it from the end of the low blood counts, where already the inflammation has caused hemophagocytosis and low blood counts. And the poor monocytes and macrophages do what they know best. They do phagocytose in the setting of cytokine release. So the end result is what the poor hemonc doctor is faced with a sick child with pancytopenia. So a hemonc doctor would look at CRS not like a rheumatologist. The CRS in the pediatric hemonc settings would clearly be in the setting of chimeric antigen receptor CAR T cell therapy, in bispecific antibody therapy, blinatumomab. And I remember when working as a fellow at Sick Kids, we used to think back at our patients with dengue and say that yes, cytokine release syndrome in CAR T cell patients is kind of a little tricky, but those of us who are trained in Asia and particularly India, where we've looked at a lot of dengue, we tend to pick up vascular fluid leak, which is the basic part of cytokine release in the hemonc settings with CAR T cell therapy. And we tend to pick up these patients relatively quickly and are able to treat them. The other setting in a hemonc setting for CRS would, of course, be post-haploidentical transplantation, and till with the post-transplant cyclophosphamide GVHD prevention. And in that setting, till you give the third and fourth day of cyclophosphamide, you can have a lot of cytokine release when you give haploidentical cells. So in these settings, just like in the rheumatology settings where you already have the diagnosis, we can anticipate cytokine release. So the diagnosis is not a challenge. Therapy can, I admit, still be challenging, and the tocilizumab model has worked well in CRS in the hemonc settings too. But what we are actually faced with is the simple general pediatrician, pediatric intensivist, challenging clinical settings. I've listed some of them: PO with cytopenia and hepatosplenomegaly, PO with lymphadenopathy, sometimes very sick children who come into the ICU already in multi-organ dysfunction, sometimes children who are in the ward who are a little more stable, but who have worrying symptoms of cytopenia, failure to thrive, recurrent infections. Some of them who come in with arthritis and truly have a leukemia. Some of them who come in with polyserositis and truly have a lymphoma. And of course, the immune deficiencies, which come in with recurrent infection and failure to thrive. So looking at it from the primary pediatrician, first presentation hemonc doctor's perspective, it's a little different. So the hemonc setting, of course, there are two questions which are asked to hemonc doctors. Is this HLH? And if so, is this primary and secondary? And it's not always straightforward till the disease process evolves. So we've seen this slide multiple times, and we know now that primary and secondary HLH are not really distinct, ends of spectrums. The distinction is becoming quite blurred because there are heterozygous mutations even in secondary HLH. And once you prove that a certain child has a specific infection or the child has an underlying autoimmune disease, then things become a little straightforward. Till that happens, it's a little tricky. So yes, all of us have looked at these criteria, and any hemonc doctor worth his salt will tell you that they don't wait for the marrow to show hemophagocytosis in the marrow to start on urgent dexamethasone and etoposide in a child who warrants the treatment. But even recent reviews, this review very recently by both a rheumatologist and a hemonc doctor, show us that how in HLH, a bone marrow aspirate and biopsy may be very, very important early in the course of disease, such that you rule out certain important differentials. Dr. Jan Inge Henter referred to this important consensus recommendations, where he is an author on this, where this is, of course, both for adults and children, and adults have a lot more malignancy associated HLH, where early in the course of disease, as soon as you suspect HLH, you may want to consider doing a marrow. You might even have to look carefully for other focuses like lymph nodes in children and rule out other triggers for secondary HLH. I'll quickly go over in the next couple of minutes a couple of case scenarios which explain how it's difficult when new patients come to us. This 2-month-old with 3 weeks of fever, first child to consanguineous parents, no focus of infection, came in with a large liver and spleen, treated already in the primary pediatric center with multiple broad spectrum antibiotics, came to us with pancytopenia. A lot of infection workup had been done, everything negative, marginally elevated ferritin, definitely elevated triglycerides, and the marrow has not shown hemophagocytosis, right? It just shows a cellular marrow. So what do we do here? Do we rule off the diagnosis of HLH? Of course not. This child was treated as HLH, and later we were able to prove that this was a perforin mutation. So the absence of hemophagocytosis clearly doesn't rule out HLH, and we wouldn't wait for repeat marrows to show it. The second scenario, a 12-year-old who came in with 2 to 3 months of fever, pallor, small generalized lymphadenopathy, a small spleen, came with pancytopenia, again, extensive infection workup negative, imaging workup negative, a marrow is normal. So we got the reference from the primary pediatric team saying, should we start on DEXA plus minus etoposide? The ferritin is high. Would you treat this child as HLH? A lymph node biopsy here showed Hodgkin's lymphoma. And so clearly a precipitous use of DEXA and etoposide would probably have been counterproductive. Standard therapy for Hodgkin's settled all the symptoms. The third scenario, a 12-year-old previously well child, 2 weeks of fever, spleen and splenomegaly of 3 centimeters, has salmonella in the blood. The fever persisted, and the primary care doctor had heard a lot about hemophagocytosis, so he was worried, did a ferritin. It was above the 500 cutoff. The marrow also showed hemophagocytosis, so urgently referred to our center. The CBC with us was normal. The ferritin was trending down. We heard about how the monitoring in serial ferritins is more important than the single value. And this child was well with no organomegaly. So clearly this was just infection-associated hemophagocytosis which spontaneously recovered. We didn't have to treat him with any immunomodulation. So I think this is the most important slide. The salient points are that bone marrow aspirate is definitely not a diagnostic test for HLH. We all agree on that. Presence or absence of hemophagocytosis does not rule in or rule out HLH. It is definitely useful to rule out underlying hematolymphoid malignancy. It does provide supportive evidence in children with recurrent cytopenias and fevers which have settled down and have not gone into extremis. And the test itself lacks sensitivity and specificity, and we've been hearing about that multiple times. So in a setting where the common theme is a relatively rapid need for a quick diagnosis, no single diagnostic test is helpful. So I would fall back on what our undergraduate and postgraduate teachers taught us and say that history and clinical examination is the key. Consanguinity, sibling deaths, previous episodes of so-called sepsis with cytopenias, and uncommon severity of sepsis could all give us clues that there's something wrong with either the immune system, primarily like primary HLH, or a secondary immune deficiency. Malignancy-associated HLH is not common in children. However, we would not want to precipitously start steroids and etoposide in acute leukemias, which would have a lot of mimics to HLH, T cell more than B cell, a lot of lymphomas, anaplastic large cell lymphoma, DLBCL, these would all present with a close mimic. I presented a case of Hodgkin's for you, and other diagnoses like Castleman's and LCH, which would come in with fevers, organomegalies, and we wouldn't want to make an incomplete diagnosis. Always remember that even if we get a viral trigger, let's say we do an EBV or a CMV and it's positive, that doesn't mean that malignancy is ruled out, because viral infections are a common trigger for malignancy-associated HLH. Our own experience, just the last couple of slides, in the last 10 years, in this 25 patients where we excluded all our secondary HLHs, we had a median age of around 7 months. It's interesting to note that in South India, because we have so much consanguinity, we had around 10 Griselles and 4 Chediac Higashi children. And while literature from abroad would have more numbers of perforin, monk, and syntaxin mutation, probably we are missing those in our part of the world. It's kind of humbling to bring to this audience that while we talk about HLH, only a small proportion of our patients were actually able to get to transplant, just 3 out of the 25. 83% responded to the HLH 2004 protocol. That's very reassuring, even in the developing world. But unless we cure them with transplant, we have a long way to go. So in summary, I would say that just like any other diagnostic test, the bone marrow does have fallacies. The history and clinical examination is important. It's important to do a marrow to rule out other diagnoses. And yes, we know that it's neither sensitive nor specific, but is an essential step to rule out underlying malignancy. So I leave you with this excellent review for any of the trainees in the audience. Thank you so much. Happy to take questions.
Thank you so much, Anand, for a wonderful talk on a hematologist perspective on cytokine release syndrome. As I see that there are not many questions here, and we want to be on time, I would like to thank all the faculty for keeping up the time and finishing on time and answering all our questions. Anand, just stay around. If there are any more questions on the chat box or the Q&A, please answer them. Thank you so much. And I would like to thank from Dr. Farhan and my side, I would like to thank the sponsors for having us as chairpersons. Thank you so much.
Thank you.
Okay, I thank all the speakers and the chairpersons for hosting the session 1. Thank you very much. It was a wonderful talk, opened up our eyes about genetic possibilities in HLH, and we spoke extensively also about role of genetics and how we use the clinical acumen to diagnose the syndrome rather than sticking to clinical criteria. So with that, we move on to the second session. And it's my privilege to welcome the chairpersons for the next session. So I would welcome Dr. Kishan Chugh. Dr. Kishan Chugh is a very senior pediatric intensivist. He was a past, he was the founder chairperson of intensive chapter IAP. He was a past chairperson, respiratory chapter IAP. He was the past director of Institute of Child Health at Gangaram. He was also the past secretary and president of Delhi IIT. He was the past associated editor at Indian Paediatrics, past chancellor of College of Pediatric Critical Care, the past vice president at ICCL. So all of those in intensive care community know him quite well. He is one of the senior most pediatric intensivists, and it's my pleasure to welcome him to chair this session. Along with that, it's also my privilege to welcome Dr. Dharmanand. Dr. Dharmanand is again a very well-known and a senior pediatric rheumatologist in Bangalore, and he is currently the president of Indian Rheumatology Association. In the past, he's been the president of IRA Karnataka chapter. He's currently a consultant and runs the rheumatology services, a very popular service at Manipal Hospitals, which is in the past Vikram Hospital. So I welcome both of you to chair the next session. Over to you, sir.
I'll start. Good evening, everybody, and thank you all the organizers for this wonderful conference, very unique conference, which has brought hematologists, rheumatologists, infectious disease specialists, and also general pediatricians and ICU specialists. And the COVID and COVID-related cytokine storm, dengue-related cytokine storms have actually advanced the frontier of knowledge with regards to cytokine release syndrome, and which has got a huge connotation for CRS related to autoimmune disease. To discuss this, we have none other than our beloved organizing secretary, Dr. Chandrika Bhatt, who did her undergraduate from KMC Mangalore and her MD Pediatrics from Grant Medical College, Mumbai, and her further training in Royal Hospital for Children, Bristol and Bath. And she currently runs a pediatric rheumatology service in Rainbow Children's Hospital and few other hospitals. And she was also a consultant in the same hospital where she was trained. And she has a number of publications and has been an invited speaker in multiple national conferences. And her area of interest are immunomodulation in ICU, that is the specialty of rheumatology and immunologists, and CRMO and uveitis. Over to you, Chandrika.
Thank you, sir. So good evening, everyone. What I'll do today is just talk about some of the rheumatological triggers for cytokine storm in children. I know we have, can I request everyone to kindly keep yourselves on mute, please? So we've had innumerable talks yesterday discussing various triggers that we see for cytokine storm, ranging from infections, and especially in the Indian scenario, dengue is a major problem that we see where children present with hyperferritinemia. But what I would like to highlight with my talk is when you see a sick child in ICU presenting with multi-organ dysfunction, also think of rheumatological triggers which can lead to a similar presentation at the onset of disease itself. So I think the audience is going to remember this umbrella from this conference very well because it has been used by multiple speakers. But the reason why it has caught the attention of so many rheumatologists is that it very well depicts the final common pathway of what we now call cytokine storm syndrome. But what it essentially means is that there can be various triggers ranging from infections, which form a large part of this trigger, to malignancy, and also we have genetic background related diseases such as familial HLH. But what is interesting here is that, as you can see, apart from malignancy and rheumatological disorders, infections can also serve as a trigger for development of cytokine storm in these patients who have a background disease. So that is why it forms a major part of this diagram. So what exactly is hemophagocytic histiocytosis? It basically means that there is an expansion of non-neoplastic, these are benign macrophages, but they go berserk, become hyperactive, and they start engulfing other cells in the body, usually platelets or red blood cells and other cell lines. And conventionally, as has already been discussed by Dr. Fabrizio and Dr. Claudia, we have divided HLH into two different subtypes, which is primary HLH and secondary HLH. But what we are now realizing more and more is that the distinction between these two subtypes is becoming more and more hazy. So primary HLH, as we all know, is because of a Mendelian inheritance, wherein there is a perforin, there's a defect in the perforin-mediated cytolytic pathways. And with secondary HLH, there are environmental triggers such as malignancy or rheumatological disorders, wherein we call them macrophage activation syndrome. And infections, again, in the Indian scenario are a big problem, and that forms a major chunk of cytokine storm that we see in ICU setting. And this diagram, Dr. Kronis in the panel as well, very well illustrates the risk stratification for developing macrophage activation syndrome. So what it essentially says is, if you're on this end of the triangle, wherein you definitely have a biallelic mutation, you're almost certainly going to develop HLH. But as we go towards the tip of this triangle, the combination of an environmental trigger or an acquired trigger becomes more and more important if one has to develop macrophage activation syndrome. So essentially, it is a combination of an environmental trigger in the background of a hypomorphic mutation. If present, the chances of developing macrophage activation syndrome are much higher. So what exactly happens in macrophage activation syndrome? So these are the two cells that are the major culprits over here. So we have cytotoxic T cells and macrophages. So normally cytotoxic CD8 plus cells, they are meant to kill any infectious trigger, especially viruses that the body may encounter. So when they come in contact with a viral infection or an infectious trigger, they are meant to negate them. But because of some reason, be it inherited or in the background of an autoimmune disease, this cytolytic activity of CD8 plus cells is kind of ineffective, and this results in poor clearance of this infectious trigger. So as is expected, the CD8 plus cells then call for more help, and for this they result in release of different cytokines, but the most important ones being interferon gamma and GM-CSF. Now, these cytokines, they again go and inform other cells in the body to come and help, and the most important ones here are the macrophages. So macrophages are one of the most important cells in phagocytosis, and they help in clearing viral or bacterial infections. So these macrophages then proliferate, they call in more macrophages to help them, and they further release other cytokines, but most importantly, interleukin-1, interleukin-6, 18, TNF-alpha, and GM-CSF. This in turn results in further proliferation of the CD8 plus cells. But unfortunately, because of the poor or ineffective killing of the virus, the underlying trigger continues to persist. And this cycle results in a vicious ongoing pathway wherein more and more number of cells are activated, and eventually they start consuming other cells in the body. And this is what we then see on the bone marrow as hemophagocytosis. As you can see over here, a macrophage has engulfed a red blood cell. So what is the clinical presentation of MAS? Usually these children are visibly ill looking, if not in the ICU. They have relentless, unremitting, very high grade temperatures. And as the disease progresses, they may develop other organ dysfunction with neurological involvement in the form of drowsiness to frank encephalopathy to even coma and seizures. They may have bleeding tendency with hemorrhages, petechiae, purpurae, and as the disease progresses, they can be liver dysfunction, cardiorespiratory compromise as well. And what we ultimately see if these children present late is what we then call a picture of multi-organ dysfunction, and a similar picture like disseminated intravascular coagulation because of the degree of consumption of fibrinogen that happens. And if you happen to see a child at this stage, in the Indian context, rightly so, we would first probably think of sepsis. But what I would like to highlight over here is always please do think of the underlying trigger that could have led to this picture. Although infections are the most common causes, malignancy and rheumatological triggers are not far behind. And if you further work up these children on investigation, what you would see is a sudden drop in different cell lines, including hemoglobin, the neutrophil count, platelet count. And a word of caution over here, in a child with an underlying rheumatological disease, if this has been undiagnosed for a while, as with any inflammatory picture, we could have a normal to a higher value of platelet count at the beginning itself. So when these children go into macrophage activation syndrome, you may still see a normal platelet count. But what is important is that they develop relative thrombocytopenia. So today, if the platelet count is say 7 lakhs, and suddenly it drops to 4 lakhs with a rising CRP, unremitting fever, other cell lines dropping, please do think of macrophage activation syndrome. Don't wait for absolute thrombocytopenia to develop. And a sudden drop in ESR is a good surrogate marker for fibrinogen, and in a resource-limited setting, fibrinogen can be expensive, so ESR can be a good reflection of this as well. Along with rising markers of inflammation, such as C-reactive protein, obviously very high ferritin levels. A lot of children with underlying rheumatological disorders like systemic onset JIA, we have very high ferritin levels as baseline itself. But when you look at ferritin levels of more than 10,000, please always do think of macrophage activation syndrome. And apart from that, other inflammatory markers, LDH, AST, ALT also follow suit, and they would go up as well. Now, because the CD8 plus T cells, when they proliferate, they inhibit lipoprotein lipase, we also see an increase in triglyceride level. Now, this is not something we commonly send in clinical practice because it has to be a fasting sample and it can be erroneously reported, but we mainly rely on the other markers and the clinical picture to make a diagnosis of macrophage activation syndrome. And as the previous speakers have already highlighted, tissue hemophagocytosis is not essential for the diagnosis of macrophage activation syndrome, but as a rheumatologist, I commonly ask for it mainly to rule out malignancy, especially in children who present for the first time with macrophage activation syndrome. Now, if you have access to fancy tests, you can ask for soluble IL-2 alpha, which just reflects proliferation of CD8 plus cells, or soluble CD163, which is a marker of macrophages. And why is ferritin so important in the context of macrophage activation syndrome? So this is a very good cartoon going back to 2007 when it was first published, but I think it still holds a lot of relevance. So as you can see, when there is hemolysis of red blood cells, you have free hemoglobin being released along with haptoglobulin. These two combine to form a hemoglobin-haptoglobin complex, and this is then taken up by scavenger receptor CD163, which is present on the macrophage, which is then degraded to heme, and with the help of heme oxygenase, it is converted to either biliverdin, which is then excreted as bilirubin from the body, or to carbon monoxide, which is then exhaled out, or to iron, which is free iron, which is then sequestrated with ferritin and is either transported or distributed to the bone marrow. Now, as you can imagine, when there is increase in lysis of the red blood cells, there is increased production of free hemoglobin, and as we go down the pathway, this results in increased ferritin levels. Now, there is a lot of debate as to whether ferritin is just an epiphenomenon reflecting ongoing inflammation and hemolysis, or whether ferritin itself contributes to ongoing pathogenesis. And this was actually well discussed yesterday by Dr. Ramanan as well. So moving to MAS in pediatric rheumatology, we see macrophage activation syndrome in the setting of a lot of rheumatological disorders. Virtually any rheumatological disorder can be complicated with MAS, but classically it has been described with systemic onset JIA, which I will be discussing next. But other conditions, increasingly SLE has also come to the forefront, that it can even present in macrophage activation syndrome. Kawasaki disease as well. Initially, there were some reports saying the ferritin levels in Kawasaki usually do not go beyond 5,000. But now we know that even Kawasaki disease can result in overwhelming macrophage activation syndrome. And autoinflammatory diseases, I think Dr. Fabrizio already has discussed the paper presented by Dr. Canna with NLCR4 mutation as well. And even with dermatomyositis, we can see children presenting with macrophage activation syndrome. So this, again, going back to this figure, this is a multi-layer model which actually shows the probability of developing macrophage activation syndrome in children with rheumatological diseases. So what it actually says is that these are the three essential triggers you need for the development of MAS, either a genetic predisposition in the form of a hypomorphic mutation, which leads to increased macrophage activation, or a defect in the cytolytic pathway, coupled with very high inflammatory activity, wherein there are very high levels of circulating interleukin-1, 6, or interleukin-18 levels, and then possibly an environmental trigger. So a combination of these pushes these children into developing proliferation of macrophages and cytokine storm with the release of further cytokines as well. And this is important to recognize because most of the times with children, at least in India, what I've seen is those who have systemic JIA, they present with macrophage activation at the onset itself. And usually there is an infectious trigger that probably tips them off to developing MAS. So I'll just discuss a couple of cases here. So this is a 13-month-old girl who came to us with a history of fever of weeks duration. Along with the fever, she had a history of an erythematous maculopapular rash, which became more prominent during these fever spikes. She had no joint swelling, was otherwise very irritable, especially when she had fever. There was no organomegaly, no lymphadenopathy. But what was interesting was this girl had a very significant past history of recurrent fever with a similar urticarial-looking rash, and she had received blood transfusion 4 months prior to referral. Unfortunately, we had no documentation from the previous hospitals to say why she was transfused or what evaluation was done at that point in time. So when she came to us, initial labs, her hemoglobin was borderline at 11 grams per deciliter. She had a very high white cell count of 47,000 with a neutrophil percentage of 80%. Platelets were 6.5 lakhs. CRP and ESR were quite high. CRP was in hundreds and ESR was 90. Ferritin was going up. It was 4,500. And her echocardiogram was normal. But looking at this episode, we initially considered a possible differential of Kawasaki disease, considering her age group, fever, rash, and we gave her IVIG at 2 grams per kg, the standard dose for Kawasaki disease. But despite this, she continued to have fever at the end of 48 hours, and this was unremitting fever. And when we repeated her labs, what we saw was all her cell lines had dropped, and this is what I was talking about earlier. So if you see over here, the WBC count and the platelet counts are still in the normal range. But what is important to recognize is that with a rising CRP, a sudden drop in platelet count from 6.7 lakhs to 2.7 lakhs is an ominous sign. And we then sent her ferritin levels, and as you can see, they were quite high at 13,000. So we did a bone marrow, again, not to diagnose MAS, but mainly to rule out any occult malignancy that this girl could have had. And the bone marrow showed evidence of hemophagocytosis, but no malignancy. So we made a diagnosis with a past history and this episode of fever with rash, although she had no arthritis, and arthritis is not necessary to actually make a diagnosis of systemic onset JIA. We made a diagnosis of SJIA with MAS and pulsed her with steroids. But when we moved on to maintenance steroids and methotrexate, which is what we started her on initially, she had a recurrence of disease. We were unable to go below 2 milligram per kilo of steroids, and she fled again with fever and rash. Now, considering the past history of recurrent fever and rash, we thought of other autoinflammatory diseases as well and sent her genetics, but it did not pick up any mutation of significance. So at this point, because of persistent disease activity, started her on tocilizumab, which seemed to hold her disease for the first few months. But later on, she again presented with unremitting fever. This time she presented with small joint arthritis as well. And again, she had gone into macrophage activation syndrome. So we pulsed her with steroids again, but because we did not have access to anakinra at that point, we then gave her a combination of cyclosporin and lenalidomide, hoping it would sort of control her disease activity, which it did for the next 3 months at least. But again, she came back with a flare of fever and arthritis. And quite worryingly for me, she came back with clubbing this time as well. So we did a CT scan of her thorax, but it did not pick up any evidence of interstitial lung disease. We also did an echocardiogram, and her pulmonary pressures were normal. So I still don't know why this girl has developed clubbing. But at this point, we again increased her dose of steroids and then started her on a JAK inhibitor, which is baricitinib. And this has worked remarkably well for this girl. And we've been able to now wean her steroids to less than 0.5 milligram per kg per day. And she continues to be in remission for 9 months. Now, the reason why I wanted to highlight this case is these children can be extremely difficult to manage, and a multidisciplinary team with probably an intensivist, rheumatologist, and hematologist all are very important in coming to these decisions. So macrophage activation in systemic onset JIA. So around 7 to 17% of patients can have overt macrophage activation syndrome. But what is interesting to note is this paper was, this was actually by Dr. Sujata Sani's paper, that around 1/3 of patients actually have mild or subclinical macrophage activation syndrome in those with systemic onset JIA. And like I already mentioned, this can be seen at diagnosis, and this is probably because of a combination of very high disease activity at the onset of disease and maybe an infectious trigger, which further adds to the picture. And the reason why this happens in systemic onset JIA, again, this is a beautiful representation. So when children have a background or a coexisting active rheumatic disease, you already have a very prevalent inflammatory milieu with high cytokines such as interleukin 6, interleukin 1, interleukin 18. And then when the dendritic cells come in contact with the virus, they further stimulate other cells downstream, such as CD8 plus T cells, which results in the secretion of interferon gamma, which then stimulates macrophages. And really, this cycle tends to self-perpetuate, resulting in overt macrophage activation syndrome, what we now call cytokine storm. So when do we suspect MAS in children with systemic onset JIA? This can be quite challenging because of the degree of overlap between systemic onset JIA and MAS, but some of the key features that we feel are helpful is a change of fever pattern. So normally in systemic onset JIA, we talk of a classical quotidian pattern, but if this changes and these children start developing persistent high-grade fevers, looking unwell even in between fever spikes, then please do think of macrophage activation syndrome, and the other thing obviously would be an intercurrent infection. And now in the world of use of steroids and biologics rampantly, there can be an altered presentation. Some of the features may be masked, some of the laboratory lab features may also be more subtle than what we would have seen if they were immunomodulation naive. And as the disease progresses, evidence of other end organ involvement, such as hepatosplenomegaly or CNS dysfunction, may also be seen. Now, the criteria for diagnosis of HLH, which was laid down back in 94 and then 2004, the problem with this criteria for use in rheumatological disorders, what they found was that it was not very sensitive for early diagnosis of MAS. And this is because there is a lot of overlap, like I said, between inflammatory diseases and MAS. And this is the reason why new criteria were then developed. And the Ravelli criteria, which was laid down in 2016, said Ferritin was mandatory, so a rise in ferritin of more than 684, and any two of the following criteria, a drop in platelet count, rising AST levels, increasing triglycerides, or a drop in fibrinogen, had a sensitivity of 73% and a specificity of 99% for the diagnosis of macrophage activation syndrome. But because there was still a lot of difficulty in differentiating patients with macrophage activation syndrome from a flare of systemic onset JIA, the MS score was then devised, which actually relies on more clinical criteria such as CNS dysfunction, hemorrhagic manifestations, active arthritis in the background of systemic onset JIA, the drop in platelet count, drop in fibrinogen, rising LDH and rising ferritin. And on this scoring, what they found was that the sensitivity had gone up to 85% and specificity of 95%. Apart from this, we also have the H score and the ESR ferritin ratio, which has already been touched upon previously, so I won't go into it. And this illustration, I think, still holds very good, which was laid by Dr. Ramanan's team, that if you see a child with fever, cytopenias, and coagulopathy, please check serum ferritin levels as baseline. In India, this is very easily available, not very expensive. And if the serum ferritin is on either end of the spectrum, less than 500 or more than 10,000, your diagnosis is pretty straightforward, is that less than 500 MS is unlikely. But if these children continue to spike fevers or they develop end organ dysfunction, please repeat a ferritin level along with other markers of inflammation. If the ferritin is more than 10,000, then MS is very likely and you'll have to go ahead with immunomodulation. But if the serum ferritin is between 500 and 10,000, the possibility of MS is still high on the cards. Discuss with a rheumatologist or an intensivist, but please check for other markers as well and keep repeating these markers every 24 to 48 hours if your patient continues to deteriorate. So with this, I'll move on to another patient. So this was a 10-year-old girl who presented with a week's history of increased thirst, weight loss, polyuria, fever, and seizures. She had very high sugars at presentation, so a diagnosis of diabetic ketoacidosis was made. She was started on insulin and appropriate antibiotics. But despite this, she continued to have fever spikes, and a repeat investigation picked up a dropping hemoglobin at 9.8, WBC of 5,900 with an absolute lymphocyte count of 590. Her platelet counts also had started dropping to 69,000. Here, if you see, the CRP had gone up. So her baseline CRP was 55. It had gone up to 138 and ESR was 25. Apart from that, other screening tests showed she had significant proteinuria with an albumin which was 4+ and a protein creatinine ratio of 3.1. Her serum albumin had also gone down to 2.6. Blood and urine cultures were negative for any infection, and she had low C3 and C4. So essentially, we were thinking of SLE over here, but what was confusing for us was the fact that she had a high CRP, which we normally don't see in children with SLE unless they have concomitant florid arthritis, serositis, or an intercurrent infection. So that's the reason why we then actually sent her inflammatory markers, and to our surprise, actually her ferritin levels were quite high at 36,000, and even the LDH and SGOT-PT was very high. And at the same time, we got the results of her autoimmune evaluation, and her ANA was strongly positive, and on biopsy, she had class 3 nephritis. So the reason why I wanted to highlight this case is that in children with SLE, MAS may be difficult to pick up because they can have cytopenia at presentation. But if you see some odd features, such as a high CRP, children having unremitting fevers despite immunomodulation, this is the time, probably apart from screening for an intercurrent infection, that you need to think of MAS as well. So like I said, a lot of overlapping features, especially with fever, cytopenias, lymphadenopathy, and hepatosplenomegaly, which can be seen at presentation. So keep a high index of suspicion. And I think neutropenia, a reversal of CRP and ESR ratio, usually the normal picture of SLE is a normal CRP with a high ESR. If you see a reversal of this, please think of MAS, and then you can obviously check the ferritin levels as well. If unrecognized, this can lead to a mortality of as high as 5 to 11%. And these are some criteria that have been devised to think about MAS in SLE. They're pretty much the same as the previously described criteria, wherein if you have one clinical criteria of fever, hepatosplenomegaly, hemorrhagic manifestations, or CNS dysfunction, along with lab criteria with dropping cell lines, increasing AST, LDH, and dropping fibrinogen, then do think of MAS. Now, moving on to Kawasaki disease, it is actually a very under-recognized complication. And in the first week of illness with Kawasaki disease, we probably would see some degree of cytopenia indicative of the degree of inflammation these children can have. But this was very well described in a recent paper in 2021 by the PGI group in India, that around 1.3% of children with Kawasaki disease can actually develop macrophage activation syndrome. So please keep a low threshold for suspicion if children have especially bicytopenia. Look at the AST levels, send ferritin levels, and that would definitely be very helpful. And the reason why we are curious to know if these children have MAS is they have an increased propensity to develop coronary artery aneurysms, and that also predicts a greater degree of refractoriness to IVIG. So if fever persists for 10 days, normally with Kawasaki disease, we expect fever to burn out by 10 days. But if fever continues beyond that period of time and you see splenomegaly, these are more indicative of development of MAS rather than persistent disease. And this is more commonly seen with incomplete Kawasaki disease. And this also carries a high mortality of around 8 to 22% if undiagnosed. And this paper has already been spoken about multiple times in the previous talks. But the reason why, again, this has got the attention was there is a genetic mutation over here that has been picked up, but this is not the same as primary HLH. So here, these children can present with early onset recurrent fevers and macrophage activation syndrome. They have normal NK cell function, which differentiates it from primary HLH. And they, in fact, have very high levels of circulating IL-18 and IL-1 beta. And this, you see over here, this child has an urticarial rash and dermatographism and splenomegaly as well on an ultrasound scan. And this is a very beautiful representation of the course of this child. So the pink bars indicate periods of flare, wherein you see the ferritin levels are very high, the platelet counts dip down, hemoglobin goes down, and the CRP is elevated, which is quite characteristic of macrophage activation syndrome. So treatment, there will be many talks tomorrow highlighting the treatment of macrophage activation syndrome, but I'll just touch upon it briefly. In rheumatology, we obviously do rely on corticosteroids. I personally prefer methylprednisolone to dexamethasone unless there is CNS involvement. Targeted cytokine blockade, we now have anakinra slowly available in India. So at least for acute setting, maybe this is something most of us can consider. Canakinumab is also a good drug, but it is unfortunately not available in India. Tocilizumab in some settings can be useful, but even in children with systemic onset JIA who were on maintenance tocilizumab, it did not prevent them from going into MAS. So in the face of cytokine storm, probably in certain settings, it might be helpful, but not always. Interferon gamma inhibitor emapalumab has gained a lot of attention worldwide, but it's still not available in India. Etanercept as a TNF-alpha blocker has had a few reports wherein it has worked, but at times it has also paradoxically worsened cytokine storm. So this is not something we would commonly use. And apart from that, if you don't have access to these drugs, HLH 2004 protocol in a modified version, as alluded by Dr. Henter yesterday, can also be used. And most importantly, always look for the underlying trigger and treat it effectively. So take-home messages: MAS is not an uncommon complication of rheumatological diseases, and most often we see it coming at presentation of the underlying rheumatological disease itself. Ferritin levels more than 10,000, please think of MAS. Demonstration of marrow hemophagocytosis is not essential for diagnosis, but do consider it if you want to rule out other differentials like malignancy. There is increasing role of genetics now in macrophage activation syndrome as well, and early recognition and prompt treatment is the key. So with this, I end my presentation and open to questions, if any. Thank you.
Thank you, Dr. Chandrika, for a very wonderful and elaborate talk. Very self-explanatory. Not many questions. Let me see. There is. I don't know. Are you seeing any?
I think there are a couple.
Yes. A new patient with MAS, when would you choose HLH protocol over the other options of immunomodulation? This is a question. In a new patient with suspected macrophage activation syndrome, when would you choose HLH 2004 protocol over other options of immunomodulation?
So I think if there is a suspicion of underlying primary HLH, then perhaps I would be more inclined towards using 2004 protocol. But otherwise, in children with rheumatological diseases, especially presenting in macrophage activation syndrome, I would be more keen on using targeted cytokine blockade. If they don't respond to targeted cytokine blockade, maybe anakinra or tocilizumab, then maybe we would consider using drugs like etoposide in a reduced dose. And we would assess the response dose by dose. We wouldn't follow the entire length of the protocol. We would probably give one dose, see the response, and then continue with further doses if they don't go into remission with MAS.
What about cyclosporine? Don't use?
So in the acute setting, I'm not sure cyclosporine has much of a role. It would probably prevent further relapses or recurrences of HLH. But in the acute setting, I probably wouldn't use cyclosporine as much.
Because we have lived in an era before biologicals were available. And we used to treat them with high-dose steroid and cyclosporine with decent results, I should say. So, but your experience is much higher than us. And my last question before we move on. SLE and systemic JA are poles apart in etiopathogenesis, immune pathogenesis, autoimmune basis. But these are the two most common autoimmune diseases which can lead to HLH or MAS. What do you think? What do you make out of this? They are poles apart, immunopathogenesis wise.
Yes, sir. So I think macrophage activation has been very well studied in children with systemic onset JIA. With SLE, there is more research going on, but we still do not have enough data to actually speak about the pathogen immunopathology as to why they are pushed into macrophage activation syndrome. And even the incidence of MAS is probably lesser with SLE as compared to systemic onset JIA. And the prototype of MAS in children has always been studied with SJI, where we have so much of evidence. But with SLE, probably we still need to wait for more data.
Our experience in adult is SLE patients who have MAS as presenting feature, they have a different phenotype. They never develop renal involvement. So they have predominantly skin systemic symptoms and autoantibodies, low C3, but they hardly develop neuropsychiatric or renal lupus.
Yes, absolutely. And this child, actually, that's the reason why I presented, that she had renal involvement at presentation itself and macrophage activation syndrome, which was a bit unusual. And rightly so, that's not the phenotype we commonly see in children with SLE presenting with MAS.
I think due to want of time, we will close this session, and I'll request my co-chairman, Dr. Chuk, to introduce the next speaker.
Thank you. Thank you so much. Thank you, Rakshay, for making me a part of this unique conference. It's a pleasure being learning all this comparatively newer things, newer perspectives into this cytokine complexity, although we were always seeing this in our ICUs. Being ICU man, what I would say is that no matter what, whether it's a rheumatological disorder or a oncological disorder, or hematological or sepsis or dengue or whatever, be the initiating factor these patients in our ICUs when they get this. So it's a great honor being a part.
Sir, your voice is breaking up.
This conference. Okay, I'll try and be louder. And so let me introduce the next speaker. He's a professor at Leeds Institute of Rheumatic Musculoskeletal Medicine, University of Leeds. In a clinical research, he has used microanatomy and imaging to elucidate the pathogenesis of seronegative inflammatory diseases and has defined the central role of enthesis in joint pathology. In several key publications, including the cytokine-mediated enthesitis theory of synovitis, in the seronegative spondyloarthritis, diseases that include ankylosing spondylitis and psoriatic arthritis. In Lancet in 1998. He runs clinic to inflammatory network with Sinisa Savic, and he has developed the modern immunological continuum classification of inflammation against self-loss medicine 2006. His group have shown how COVID-19 immunopathology is distinct pulmonary pathology that differs from classic MAS and DIC. Again, published in the best journals. His group has defined normal human enthesis in and adaptive immunity, including gamma delta T cells and conventional T cells in human enthesis. Dennis is section head of experimental rheumatology at Leeds Institute of Rheumatology and Musculoskeletal Diseases. He has served on the editorial boards of Arthritis and Rheumatism and Annals of Rheumatic Diseases, and has served as a member of the Scientific Committee of the European League Against Rheumatism, and is co-chair of the EULAR task force, and has so many more international prizes that he has won. So over to you, Dennis.
Thank you, Christian. Can you all hear me? Yep.
Yes, we can hear you well. We can hear you well.
Yes. Sound wasn't great there when Christian was introducing. Thank you, everyone. Thanks for asking me to speak. Moving towards precision medicine, role of cytokine profiling. And I'll talk about moving towards precision medicine, but as you will see, I'm not sure about the exact role of cytokine profiling. A lot of potential conflicts. I work with some companies that are in the auto-inflammatory space. So I'll talk about cytokine hyperactivation, hyperinflammation, cytokine storm, whatever you wish to call it. I will be discussing how the COVID-19 pandemic has provided a springboard, and everyone's really interested in this now. And I'll be talking about the immune cartography, as we call it, of cytokine storm. And I will basically be setting the scene for you Indian physicians around your approach to viral hemorrhagic fever is there anything in my talk that might be useful, basically? So at the start of the pandemic, if I can bring you back 2 years, it's all melded into one long year because there's no travel. But at the start of the pandemic, we had papers talking about a cytokine storm. And indeed, here we have patients with like this is 10,000 picograms per mil. The levels of IL-6 were so high that it had to be expressed in nanograms per mil. It was so high. And another interesting thing about the coronavirus pandemic is that people don't die quickly. They take 2 or 3 weeks to die. And this gives physicians lots of opportunities to use drugs. This may not happen for other illnesses where the infection can rapidly progress. So, and the other thing about the coronavirus pandemic, the coronavirus SARS-CoV-2 isn't particularly destructive in the lungs. It does lead to ARDS eventually, but it doesn't lead to lots of lung destruction. And this cytokine storm analogy caught on very quickly. And here's a paper showing that everyone treated with tocilizumab in China, in this PNAS paper, everyone got better. But in this paper, the levels of IL-6 had come down from over 10,000 picograms per mil to a more modest 153 picograms per mil on average. So the first thing I'm making the point is measuring cytokines, what does it tell us? And of course, many features of the severe coronavirus COVID-19 disease with multi-organ inflammation are not dissimilar to the hypercytokinemia and activation you see in classical macrophage activation or in CAR T-cell therapy, particularly CD19, anti-CD19 therapy for lymphoma disease. You see this multi-organ inflammation and coagulopathy. So at first level, all of these things look very similar. And yes, there did seem to be a logic for a full steam ahead approach with cytokine blockade in severe coronavirus disease. But when you look, as the last speaker mentioned, in classic macrophage activation and CAR T-cell therapy, the levels of interleukin-6 are really very high. And ferritin, hyperferritinemia is very characteristic of cytokine storms associated with MAS. And this is a CAR T-cell therapy cytokine storm. And the most severe disease have ferritin levels in the range of 100,000. So you rarely see this in COVID-19, 1/100th of the level on average, I would say. And so does the COVID-19 hyperinflammatory disease, which we treat with steroids and tocilizumab, is it really a cytokine storm? And here's a paper from China, which is highly cited. And if you look at the mean values of IL-6, they're actually 11 picograms per mil. And now, as we're well into this entity, we see that even people with normal CRPs and not particularly high ferritin seem to be responding to therapies. So the whole idea of the classical cytokine storm and the original papers and claims that were being made around a cytokine storm with this virus are, you know, you see the evidence, I'm not so sure. So what about the COVID-19 pathology? And the key point I'm making here is that when you're looking at using cytokine antagonism in other viral diseases such as dengue fever, which is obviously a big problem for you in India, unlike the UK here. So you need to take a look and go right down to the very basis of pathology. And I'm just going backwards, excuse that. So obviously COVID-19 causes an alveolitis. So it's right in the alveolar territory. This is from my friend and collaborator, Lucas Catercio, in the north of Italy, who sent me this picture at the start of the pandemic. And you see it's very much a ground glass alveolitis without tissue destruction. And basically the pathology of the pneumonia is played out in the alveolar territory, which is up to 500 million alveoli, which covers the same area as a badminton court. And obviously some of the best badminton players in the world are Indian. So this is where the pathology is played out primarily, and I'll be talking about this. So this CT scan shows somebody going for surgery for lung cancer, and they have a pleural effusion linked to the lung cancer. And on the morning of surgery, they have a staging CT, and they're asymptomatic, and it shows ground glass changes of COVID, asymptomatic. And when the histology was done on this incidental COVID infection, the predominant abnormality that was evident was this is a case report. There's two of these. The predominant abnormality is macrophage infiltration of the alveoli in this pneumonia. So there is macrophage activation, but it's in the alveolus. And this is the battleground state in this pneumonic process. The alveolar type 1 interferon response initially doesn't control the infection, and then this leads to local immune activation. Now, in flu, which can be rapidly fatal, 3 or 4 days, and hemorrhagic necrosis and destruction of the trachea. Here is the severe bronchopneumonia. It's bronchial. Here's the cartilage in the trachea. Lots of vascular thrombosis in large vessels and tissue destruction and dehiscence, and steroids don't work. So that's fatal flu. But the distribution of the coronavirus infection is in the alveoli, and the alveoli are closely juxtaposed to thin-walled blood vessels. And this sets up the scenario for the thrombosis. So we pointed out at the beginning of the pandemic that this alveolar-centric territory is leading to a diffuse immunothrombosis because the ACE2 expressing cells are very close to the vasculature. So the vascular pathology is immunothrombosis, and it's very extensive. And this is generally different from flu on the right, which often has a bronchopneumonia. Now, there is lots of like immune cells at these sites of vascular thrombosis because the immune cells are moving out of the vessels into the alveolar network. And this was originally called a viral endothelitis. The supposition was that there was primary endothelial infection. Now, this extensive thrombosis involving thin-walled vessels is associated macroscopically with pulmonary tissue infarction and lots of necrotic tissue in the lungs. And here we have loss of tissue architecture and frank thrombosis of pulmonary arteriolar and venular circulations. This is a paper from Fox from the USA, again showing this thrombosis involving these relatively large vessels. As I say, these are thin-walled vessels, so they are getting caught up in the immunothrombotic process. So we made the point that, hang on, all of this vascular thrombosis, which is key to prognosis, is a physiological immunothrombosis to try and contain the viral infection to the lungs. Now, one of the interesting things is when you treat critically ill patients with anticoagulants, they actually do slightly worse. And that's because you are stopping a thrombotic process that is designed to keep the virus in the lungs and not in your cerebral cortex or your kidneys, for example. Now, of course, in milder non-critical COVID-19, anticoagulation may have a benefit. And this may be because it's beneficial in obese patients who are not able to tolerate the diffuse immunothrombosis, but this hasn't been formally resolved. Now, you heard in the last talk, which is rather beautiful, that how DIC is a feature of macrophage activation. And the original work said DIC was a feature of the coronavirus disease. And we pointed out that in the coronavirus pneumonic process, we call this a pulmonary intravascular coagulopathy, and we highlighted it amongst other things that the fibrinogen levels are high and not low. And although the FDPs and D-dimers are increased, other factors such as platelets may be normal. So it's basically a completely different pathology that's emanating from the lung. Now, in DIC, which I'm not going to go into, you have systemic macrophage activation and hemophagocytosis. Now, in this lung pathology, you get a rupture of the capillaries and arterioles, and blood cells extravasation of red cells into the lungs, and some of these are carried off to the regional lymph nodes, and you will see hemophagocytosis in the lung tissue. But this is extravascular sites of tissue injury. It's like a bruise. It has nothing to do with DIC. It's completely different pathology. Now, don't get me wrong, in severe COVID, in the pre-terminal stages, some people can progress to a DIC. That does occur, but what I'm talking about is most people with disease. Now, a critical thing in this pandemic has been the idea that there's a infection of the endothelium driving the disease. But there's many papers now showing that there's lack of productive viral infection of endothelial cells. So of course, the virus can get taken up and get into endothelial cells, and you can see that on EM, for example, but it's not replicating here. So here we have these vero cells, which are very susceptible to infection, and there's like up to 100 million viral particles being shed. But in human endothelial cells, there's very, very low levels of viral particles recovered. So there's very little evidence of productive infection. So the reason I'm highlighting that is you guys are dealing with viral hemorrhagic fevers and dengue. And there may be an issue around what the dengue virus could be doing in the endothelium. But I would say that productive viral infection of endothelium being treated with immunosuppression, as I wrongly have done once or twice in retinitis, which we thought was immune driven, and we give the patients steroids, and it turned out they had CMV, and the retinitis, the endothelial infection, quickly gets worse. So the fact that steroids are not harming these patients is certainly very much supports the idea that they don't have a primary endothelial infection. So again, we highlighted this near the start of the pandemic, that there's at least 8 mechanisms where you could have lots of endothelopathy or endothelial activation and immunothrombosis that are a mechanism to contain infection rather than an active viral endothelitis. Now, another thing that's very important to highlight from this pandemic is that the patients with the worst outcome, group 1 here, the ones who die the most, these are the ones with the highest IL-6 levels, but also detectable viral RNA in the bloodstream. So again, this has not really been teased out properly, but the feeling is that immunosuppression in people with RNA in the circulation may not be such a good thing, whereas people with lower CRPs, i.e. not cytokine storms, without that destruction of the alveolar network and less viral circulation or viral debris circulation, may do better. Again, this is not completely resolved because people have not been systematically measuring the RNA-EMIA. So basically, a PCR evidence of viral debris. There is some papers showing viral particles occasionally in the circulation, but not many. So we've highlighted this recently in one of the Lancet rheumatology article, talking about the therapeutic implications of ongoing viral replication. And so you guys are obviously gearing up towards treating dengue and viral hemorrhagic fevers with immunosuppression. But we're just making the point here is that, hang on, there may be some people where the virus is not clearing after 10 or 7 days in coronavirus disease, and maybe you want to be rather careful in jumping in with immunosuppression. And we've highlighted this here, that if you have lots of immunothrombosis and the virus is not replicating, then immunosuppression could be very good. Whereas if you have lots of viral replication and RNA-EMIA, maybe immunosuppression isn't so good. And as I say, this is an open question. So just putting the COVID-19 hyperinflammation in context, 15 years ago, Michael McDermott and myself devised this classification of inflammation against self from innate immune to autoimmune, or autoinflammatory to autoimmune. And we and others, Grad 2 in France, have said, oh, you can actually put gain and loss of function, like immunodeficiency states with loss of function, and then states with gain of immune function like familial Mediterranean fever or TRAPS. And you can also put these into this classification. Now, if you look at children with primary HLH or peripheropathies, at the end of the day, the inability to kill CMV, EBV, and typically herpes virus drives gamma interferon. And this drives macrophage activation. But of course, in adult on pediatric Still's disease, and the last talker, the speech nicely pointed out that some MAS phenotypes in kids do have associated immunodeficiency, but there's many of these kids that have no evidence for immunodeficiency, particularly monophasic Still's disease. So what we highlighted here is gain of function in the immune system, or engineered gain of function will drive excessive gamma interferon, and this will give the same phenotype. But of course, the therapy is very different. In this group, you have to treat the immunodeficiency and go towards a bone marrow transplant. Otherwise, you could kill the patient quickly. Where in this other group on the right, you can treat them with immunosuppression. So the cytokine storms are completely different. And this is something Ram and myself and Charlie Bridgewood published in Nature Reviews recently. So to highlight, when you're looking at the COVID-19, the issue is, or other viral diseases, that there may be an immunoparesis with reactive increase in innate immune cytokines giving hypercytokinemia or relative increase in cytokines and a pulmonary specific macrophage activation, completely different from MAS and cytokine storm. And we published this article at the beginning of the pandemic, and we're saying these things at the stage when everyone was saying, let's give steroids and tocilizumab. And we said, maybe that these things could be detrimental and they could actually do harm. And of course, the recovery studies showed that in some group, steroids actually did do harm. And when you look at the meta-analysis of all the RCTs of tocilizumab and coronavirus disease, as you can see, many of these studies were completely negative, particularly the blinded RCTs. The biggest platform study, recovery, was positive, but it's not completely blinded. So the benefit of cytokine suppression overall has been rather incremental, like an absolute reduction in mortality, or a 3 to 4 percentage point reduction in mortality, not the spectacular reductions you see in mortality when you use tocilizumab for a CAR T cell therapy cytokine storm. So I talked about the loss of function in the cytokine dysregulation in COVID-19. So we also made the point that if you quickly could control the virus and kill it, and you had an immune hypersensitivity reaction, you could get gain of function in the system with COVID, which we think occurs in MAS, in SJIA, and adult stills, and with CAR T cell therapy. So if you quickly control the virus, you might have another scenario. And indeed, this scenario came along in COVID under the umbrella term of MIS-C, this multi-system inflammatory syndrome, which can manifest, amongst other things, with a Kawasaki-like disease. And I refer you to the wonderful talk I just heard, mentioning how a MAS-type phenotype can be a part of Kawasaki. So we highlighted this, that the CAR T cell therapy and the toxicity in MIS-C are not dissimilar. And in these kids, you don't usually recover the virus from the throat because it's rapidly controlled, and the children may be antibody positive and they don't usually get a viral pneumonitis. So this is more a gain of function scenario where there's no recoverable virus. So again, if you're treating a hemorrhagic fever with cytokine blockade, you probably want to be targeting those patients where the virus is already under control or cleared. This is the clear message that I seem to be getting from this. Now, with respect to the coronavirus, many of us are rheumatologists. There's this issue that vasculitis occurs in the lungs. And here are nice examples of vasculitic inflammation in the pulmonary arterial tree, lots of vasculitic inflammation. But one of our fellows, we've written an article on this, and what's happening, everyone, is we think that all of this inflammation spilling out into the interstitium basically captures these thin-walled blood vessels, which are infiltrated by inflammatory cells. So it looks like vasculitis, but it's not. Now here is COVID toes, which children get, and these children don't usually have pneumonia, they're otherwise well. And this has been looked at by Cynthia Magro and others, and what it's nicely showing is that these kids get a cutaneous lymphocytic vasculitis with this lots of interferon protein expression. This is MX1. So this is a type of immune gain of function to the viral infection where there's an overreaction to control the virus, and this leads to this type of vasculitis. So again, virus is nowhere to be seen, but the immune response to the virus drives this scenario. Now, there is another scenario that critically ill patients in ICU get, and these people get immunothrombosis in the arteriole and venous tissue in the skin, and it's posse-immune, and there may be complement activation due to ischemia. And we proposed in another paper last year that some of this is a novel immunothrombosis due to clots escaping from the pulmonary venular territory and going systemic. And this is not completely proven, but there are many case reports showing large thrombi in the pulmonary venous side now. So to put it in the context of COVID, you have a viral infection largely confined to the respiratory tract and alveolus. And on the other side of the equation, you have the immunothrombosis in the vascular tree trying to keep that in the lung. Now, this is completely different to dengue hemorrhagic fever, where, as you guys know much better than me, you have a nasty pathogen that has hitched a ride on circulating myeloid cells. And this is completely different. So I would not deduct too much about the benefits or other ways of therapy with immunosuppression to SARS-CoV-2, to viral hemorrhagic fever. So just to finish up in the last few minutes, so Ram, myself, and Charlie devised an immune cartography for MAS in the COVID era. So of course, MAS has this unique feature that the macrophages that are eating the erythrocytes are doing so in the hepatoid sinusoids, spleen sinusoids, and bone marrow sinusoids. So the macrophages are pulling otherwise normal red cells out of the circulation. So that's what happens in classic MAS, and that's why you get hepatosplenomegaly and lymph nodes. And this is a pretty unique feature. And of course, you know the cytokines are familiar with gamma interferon appears to be a very big player in this scenario. And empirically, we know that anti-IL-1 therapy works. Now, rather than telling you about measuring individual cytokines and precision medicine, I personally don't think it's possible. I know there are papers in the literature showing the value of combining IL-18 and maybe gamma interferon to help identify SJIAs that are more prone to get MAS. I think more work is needed. But in this paper, we just highlighted that in different settings in vivo, in animal models and in humans, you can drive a MAS phenotype with individual cytokines, including type 1 interferons, or even feeding toll agonists. Toll-9 agonists will drive type 1 interferon. And all of these give a MAS phenotype. So there are many ways to get MAS, and even overactivity of IL-4, the archetypal good guy M2 cytokine, macrophage 2 phenotype, experimentally can drive hemophagocytosis. And IL-10 appears to be a cytokine that tries to smooth this over and switch it down or reduce it. But as I say, this is a complex area, and it's a bit of a mystery to me why targeting one cytokine like IL-1 and SJIA particularly, or IL-6 in the CAR T cell therapy is so beneficial, because it looks like there's many ways to arrive at this. Now, in cytokine storm scenarios, a capillary leak syndrome due to endothelial integrity, breakdown, and extravasation of albumin and other molecules into the tissue can play a big role, but sometimes this can dominate the cytokine storm picture. Also, I just want to highlight that this MODS, multi-organ dysfunction, when patients are septic or when you feed them too much toll agonist, they can get multi-system disease and immune activation, which is completely different to the MAS phenotype I've just been showing you, or the capillary leak syndrome. and it should not be labeled under the same umbrella. And I know RAM doesn't like this. SIRS or MODS definitions are not very helpful. They're not addressing underlying pathology. And again, particularly for this audience, what happens if the cytokine storm is actually due to viral activation of circulating myeloid cells? And then these macrophages will produce tissue factor, and then this will kick off an intravascular pathology, and it will lead to a picture which looks like disseminated intravascular coagulation superficially, but it's very different as the pathology may be being carried around the blood in the circulation. And of course, we know that when coagulation is activated, that this in turn, through many connections, can activate cytokines. And of course, cytokines, including IL-1, can activate the coagulation cascade. So coagulation and immunity are inextricably linked in the process of immunothrombosis, whose job it is to stop pathogens wandering around the body from the portal of entry. And just to say for you guys, thinking about the effect of viral hemorrhagic fever, is it directly activating the endothelium? Could there be infection, or is it a non-specific effect from the macrophages? We don't know. Obviously, I'm speaking to an Indian audience, and obviously I want to highlight this elephant endotheliotropic herpes virus. So it's basically a virus that affects Asian elephants, and it specifically affects the endothelium. And here's a cytomegalic change in endothelium. So this endotheliopathy can lead to a macrophage activation, DIC thrombosis phenotype, but it's no such thing compared to what we have been talking about in relationship to MAS and coronavirus infection, which is completely different from MAS. So I guess what I'm emphasizing here is you have to come down, identify your pathogen, and identify the primary cell type and the immunopathogenesis. So to finish up, Ram and I and Charlie, we said, well, the MAS phenotype is along an innate to adaptive spectrum, and it can be loss or gain of function. So for example, if you have an EBV infection of B cells, that's loss of function. It's B cell and it's adaptive immunity, and it can lead to a MAS phenotype, and we would treat that with rituximab to kill the lymphocytes. Alternatively, you could have an NLRCR4 gain of function. Again, I refer you to the last talk. Excellent, beautiful, sets the scene. Gain of function here in innate immunity is sole criterion that is sufficient to drive a MAS-like phenotype. So just to highlight, innate gain of function to adaptive loss of function, giving MAS phenotypes. And again, this is to highlight how there's many tissue-specific bases for giving a MAS phenotype. And I would highlight here that overactivation of the toll receptors, toll9 and lupus DNA may be sufficient to drive a type 1 interferon response that would be sufficient to drive a lupus MAS phenotype, but it's completely different. It's lupus, it's a different disease. And although it's a MAS-like phenotype here in Leeds, we just treat the lupus. We wouldn't worry so much about calling it MAS. We'd be very aggressive at treating lupus. And this is one of my last slides. It's just to highlight that if there is infection driving a MAS phenotype, and you guys know this better than me, in primary HLH, you treat the infection before you treat the MAS. Whereas if it's an adult or a SJA Stills phenotype, particularly if it's monophasic, that is not an immunodeficiency in my book, then you just come in and you target the MAS pathway, and you don't worry about infection. Well, of course, we usually use broad spectrum antibiotics for a few days in many cases. So to summarize, the COVID-19 SARS-CoV-2 pandemic is a newly defined viral pulmonary immunopathology. It's unique. It's different to MAS, which we've been seeing before. Immunothrombosis is a key feature. Most people don't go on to develop MAS of the ilk we see, but it can happen. And excessive immune responses definitely occur. The question is timing of therapy in those that have overcome the virus. There has been an incremental benefit of immunosuppression in SARS-CoV-2, many negative phase 3 studies. And what I've been trying to do is to set the scene for giving you guys a new way of thinking about viral hemorrhagic disease and hyperinflammation and the merits or otherwise of coming in with immunosuppression. So I'd like to acknowledge all of my colleagues, Charlie here in Leeds in particular, international people including James O'Donnell, Anto Regan and Jim Meany, and Abdullah and Kazim in Israel, and also Ram, who's been working with us on these models. So with that, I am extremely grateful for you asking me, and I'm happy to hand back to central control and field any questions if you have them. Thank you very much for listening.
Thank you so much, Dennis. That was a brilliant talk. I think it explained almost anything that we wanted to know about COVID-19, and in fact, much more. It was so well illustrated, and your original work on it just so.
Thank you.
Yeah.
I think we lost him.
I think, Dr. Chug, your voice is breaking up. I think we're unable to hear you.
And I'm sure everybody enjoyed it. So if there are any questions, Chandrika, maybe you can start fielding them.
I think there's just one question in the chat box, which says, so for COVID, so the question is, for COVID, we give vaccine to
great.
immunity against.
I'm so sorry.
Antigens.
If Chandrika can take the questions.
Sure, I'm doing that. Thank you.
Yeah. Can you ask a question again about the vaccine?
So the vaccine is used to induce immunity against viral antigens. So when a patient with COVID becomes critically ill with respect to respiratory compromise in the form of progressively worsening hypoxemia, we get very high levels of CRP, ferritin, IL-6, and D dimers. So the first line of treatment here is steroids and several immunomodulators, like we know, like tocilizumab and other MABs that have been used to suppress cytokine storm. So the question from Dr. Parag is, how does vaccination work to prevent serious manifestations of COVID versus a serious patient of COVID who needs immunomodulation? And why does vaccine not promote immunoreaction that could actually worsen the disease process?
Well, thank you. Lots of questions here. So first of all, the vaccine by priming adaptive immunity means that when the virus comes into the alveolus and people are vaccinated, they still pick up COVID, respiratory, they still transmit. And this is true for all vaccines that are systemically given. You get protection from severe pneumonia because of the adaptive immunity is primed when the virus arrives in the lung, and the virus is controlled in a small area, so people it stops people getting very, very ill. So that's what's happened to the vaccine. It stops serious or fatal disease or hospitalization or ICU, but the rate of infection is still very high. So the vaccines do not provide mucosal immunity. So that's why that happens, but they protect the lungs when the virus is aspirated down. It replicates in the nose, and then it's aspirated down after a couple of days. So that's the vaccine issue. So I'm not sure, but in a patient like this, obviously when they're sick in the wards, there would be no role for a vaccine. It wouldn't have time to work. This particular case, so what I'm saying here, if people are critically ill on ventilators in ICU, then there's not much evidence that the steroid or tocilizumab work. You need to get them when they are hypoxemic and requiring oxygen prior to ventilation. And that's when there is a definite benefit. But the benefit of adding the steroid is it's a bit of an absolute reduction of 4% in the positive studies. And in the negative studies from Brazil, the studies were stopped for futility. But I fully agree. The point I'm making is the virus is quickly cleared in some people. They have extensive non-viral immunothrombosis. So the steroids and tocilizumab help clear the thrombosed pulmonary vessels, and that allows the blood flow to go through, and then the people recover. So I think that's a specific mechanism of efficacy of immunosuppression, the borderline efficacy of immunosuppression in COVID-19 pneumonia. And what I'm saying is you could not extrapolate that to a viral hemorrhagic fever, which is a completely different mechanism of immunopathology and coagulopathy.
Thank you. And just one more question before we move on to the next session. What are your thoughts on the use of baricitinib in COVID-19?
Yeah, absolutely. So that's the largest randomized controlled blinded studies. They've done three studies, and they were fully blinded, and they showed a clear benefit of baricitinib, including on people that were ventilated. And there's also a study from Brazil, which is smaller, on tofacitinib. So absolutely, in these patients who are not responding to steroid, and the baricitinib data showed efficacy both in people on steroids and those not on steroids. So at the population level, baricitinib said definitely has shown benefits. So steroids, tocilizumab, and baricitinib have the strongest evidence for efficacy. I was just making the point that in many of these critically ill patients, there is RNA, viral RNA in the blood, which means there could be viral replication, and the prognosis or the outcome might be better with immunosuppression if we could treat the people without active viral replication. And immunosuppressed patients can have viral replication for months. So that's the point I'm trying to get at.
Okay. So thank you so much, Dr. McGonigal, for that wonderful lecture. There are a couple of more questions in the chat box. If time permits, we request you to just answer those questions in the chat box itself. So with this, we move on to the next session. And for this, I would like to invite our mentors, Dr. Krishan Chugh and Dr. Randy Cron. And it's my privilege and honor to introduce Dr. Cron, who is the Director of Paediatric Rheumatology at University of Alabama at Birmingham. He's also a physician scientist and runs a lab that focuses on the role of heterozygous mutations in familial HLH and genes contributing to cytokine storm syndrome. So welcome, Dr. Cron and Dr. Krishan Chugh. I now call upon our moderator for today's session, Dr. Rakshesh Shetty, and our presenter, Dr. Pavitra Vishwanathan, to kindly start the next session. Thank you.
Thank you very much, Dr. Chandrika. This is a case scenario. Like yesterday, we're going to discuss a couple of cases today. The cases what we have chosen today is related to dengue. So it was a wonderful talk by Dr. Dennis, and he said the challenges with regards to starting immunotherapy in patients with infections. And he highlighted how certain group of patients, even in COVID, are not great candidates. And I think we all kind of echo with that kind of sentiment. And there are issues even with the influenza. For example, there are certain segment of patients who do develop immunoparalysis. And those are the ones who struggle and develop a lot of secondary infections and complications. So what we are going to do here is going to discuss a couple of cases on dengue. And looking at our own experiences over the last few years, what we thought was there are a certain group of patients who might actually benefit from immunomodulation. And that is something we started doing this year. So based on this year's experience, we selected a couple of patients with two differing manifestations. And I think a lot of discussion around this started yesterday with Dr. Ramanan and subsequently Dr. Joe Carcillo, bringing up the importance of managing hyperferritic sepsis. And it's fantastic to know Dr. Randy Cron also with this studies done on interleukin 1 blocker, that's anakinra, its role in hepatobiliary dysfunction, and how it might actually improve outcomes, particularly those with bacterial sepsis and hepatobiliary dysfunction. So this I would request our fellow, Dr. Pavitra Vishwanathan. She is doing a fellowship in pediatric intensive care in our unit, and I would request her to present this couple of cases. What we would do is we would break in between, and we would ask the questions to our experts and take their opinion about what their thoughts are on with regards to management of these cases. Yeah, go ahead, Dr. Pavitra.
Thank you, sir. Thank you for the kind introduction. Good evening, everybody. Today we'll be presenting 2 cases of severe dengue whom we managed in our unit recently. I thank you all, and I thank Dr. Akshay for giving me this opportunity to present in this international forum. So this is Master O, 8-year-old, who admitted to us with a pre-admission history of 5 days of high-grade fever requiring round-the-clock antipyretics, and on day 4 of illness, he was noticed to have abdominal pain, loose stools, and 2 episodes of melena. Labs outside showed a significant hemoconcentration with a drop in platelets and NS1 positivity by day 4 of illness. On arrival to our ER, he was noticed to have cold peripheries with almost non-palpable pulses. He was significantly tachycardic, his CFT was prolonged, and he had narrow pulse pressures. And POCUS showed collapsed IVC with signs of significant leak. We initiated him on a 10 ml per kilo bolus and a vitamin K, and he was shifted to ICU. Despite this bolus, he continued to be in shock, and signs of ongoing leak was present on our ultrasound assessment. He had significant metabolic acidosis, raised hemoglobin of 18.7, leukocytosis with a thrombocytopenia. His metabolic acidosis was significant with a lactate of 6.6. What we have noticed in our patients is patients who present with shock in dengue usually tend to have coexisting sepsis. So post cultures, we initiated him on meropenem and colistin within an hour of admission. By this time, he was already initiated on his second colloid bolus. Despite receiving multiple fluid boluses and a PRBC transfusion, he continued to be in shock. As is our unit policy, any severe dengue patient receiving more than 30 ml per kilo bolus over a 3-hour duration, we initiate them on intra-abdominal pressure monitoring, as they generally go on to have significant leak, raised intra-abdominal pressure, and drop in urine output. If we can take a moment to look at this first 4 hours after his admission to ICU, what we can see is that he had already received 3 colloid boluses. He had received 3 colloid boluses here and a Paxil, despite which his heart rates tended to be high, and he continued to have this narrow pulse pressure. Moving on. By 6 hours into admission, we received the above following labs. Ferritin was 36,352 with elevation of LDH. There was significant transaminase elevation. OTs were 1,713 and PTs were 230 with hypoalbuminemia of 2 and bilirubin of 0.7. He also had associated coagulopathy. His CRP was normal, and 2D echo had normal biventricular function with normal coronaries, with COVID IgG being positive.
All right, so thank you so much. Let me pose a question to both Dr. Randy Crown and Dr. Kishanchuk. And Dr. Kishanchuk would agree with me that this is how typically a very sick dengue would present. Someone with a 5-day history, very narrow pulse pressure, in shock, significantly acidotic. As we can see, there's lactic acidosis with the lactate of 6.6, minus 24 base deficit, and this patient is heavily hemoconcentrated. Hemoglobin is driven up to 18.7 and has a low platelet count. So my question to Dr. Randy Crown is, would you consider this patient as hyperferritemic sepsis, and would you consider giving immunomodulation? And would this be the right moment to start immunomodulation?
Yeah, so I'll caveat this with, I've never taken care of dengue fever and hope to never have to. But, and to counterbalance a little bit of Dr. McGonigal, you definitely need to treat infection for sure, and you need to do what you do in the ICU to keep patients alive. But if there is a component of the immune response that's contributing to the patient's demise, you also need to treat that. And not all immunomodulators or immunosuppressants are the same. And so I think the hyperferritinemia, the DIC-like picture that's developing, the low cell counts, the elevated liver enzymes, could be a gazillion things, but I think cytokine storm's pretty high, at least on my differential. And so this is a point where I personally, and you'll hear about this tomorrow if you tune in, I'm a big fan of anakinra, because it may not suppress your ability to eliminate whatever infection you have to a large degree, but it will make a big difference, including in things like capillary leak. I've seen patients with non-dengue capillary leak in ascites even with just 1 or 2 doses of IL-1 blockade, fix that. So I certainly would keep it high on my radar and start getting the other tests that are going to be more confirmatory. But I personally would also probably start using IL-1 blockade in the form of anakinra, because it's got a short half-life, it's safe, it's a recombinant human protein. It's not completely benign, but its benefit to side effect ratio in the setting where you may have a cytokine storm, I think is pretty good.
And what's and unfortunately in last 6 months or so, many of us land up doing a COVID test, and especially when they come with fever, and the COVID antibody test does come positive. So how do we make sense of it? I mean, many times it becomes kind of difficult for us to differentiate from MIS-C versus dengue at times. Do you think this COVID serology might change the way these children might manifest, or it's just a manifestation of we being in a pandemic and we just do a blood test and incidentally many of them do come COVID positive?
Yeah, I mean, you got to take each patient as their own and try to weigh it all together. We've certainly seen patients who have had multiple COVID infections. We've also seen a lot of patients with MIS-C, only because we're a tertiary care hospital. It's not all that common, but at our hospital, it's very common. And again, anakinra is probably not going to hurt an active COVID infection. And in fact, there is now one study in Nature Medicine from a group of, I think, primarily intensivists in Greece, who found that anakinra benefited COVID. And again, the timing is really important. And I think that was in part what people were asking about with Dr. McGonigal. You don't want to be giving broad immunosuppression with things like glucocorticoids when the virus is going nuts. And there's some data suggests that early during infection, that's harmful. And one of the reasons why the World Health Organization early on, based on prior SARS and MERS, although some of us were suggesting steroids, they were saying don't ever use steroids for SARS-CoV-2. We're talking like February, March 2020. But that's right. Early in infection, it probably does make things worse. But later in infection, there is some benefit. Again, as Dr. McGonigal mentioned, it's not a huge benefit for this particular infection. But early on, I even feel comfortable using anakinra. And in that study, they used it pretty early in their patients with infection.
All right. So any comments from Dr. Chugh?
Can you hear me?
Yes, we can hear you.
Okay. So I think the most important thing here is yes, there is sufficient evidence to say that there is a cytokine overreaction, storm, whatever you want to call it. It's a hyperimmune status that the patient is in, and probably dysregulated immune response. All things put together, this does call for simpler, maybe intervention like a steroid or pulse therapy, or maybe an IVIG. My personal preference has been dexamethasone in this kind of situation. Another one who's worse than this, I might use a pulse therapy with methylprednisolone, something like 20 to 30 milligram per kg. But in this situation, a usual standard protocol of kind of old HLH with dexamethasone would be my first choice. Putting everything together, yes, we also feel that there are patients in whom probably viremia continues, and that's where if we use these drugs, they may actually harm than do any good. But most of the times, this kind of picture we see in a child who's already been into the illness for 4, 5, 7 days. And it's at that stage, then you start seeing this ferritins shooting up and all other parameters showing that it's a immune dysregulation. So I would say I would be preferring to use steroids at this stage.
Thank you so much, Dr. Chugh. And I think one of the benefits, at least we have, is that we can measure NS1, which kind of helps us about presence of viremia or not, and presence of generally serum test in terms of serology, IgM and IgG kind of points us that the viremia phase is over and we are more into an immune phase or a critical phase of this illness. So thank you so much for both of your inputs. Dr. Pavitra, please go ahead.
Yes, sir. So for us, at 4 hours, he was extremely sick, and our labs were showing evidence of evolving hyperinflammatory state. With background of sepsis being one of the possibilities, we tended to move away from steroids and we initiated him on IV immunoglobulin and anakinra. IV immunoglobulin for its possible modulating effects on elevated pro and anti-inflammatory effects and the possible role of the immunoparalysis which sets later on. The initial 12 hours, if you can see, the pre and post immunomodulation, the first 6 hours, he required multiple fluid boluses, despite which his heart rates tended to be high and he had narrow pulse pressure. Post 6 hours, if you can see, his heart rate slowly starts coming down. The systolic started going up and the pulse pressure started widening. As far as fluid requirement, the initial 4 hours, he had received nearly 4 10 ml per kilo boluses of colloids and packed RBC. The red part is our colloid requirement and the blue is our crystalloids. If you can see, even after 4 10 ml per kilo of bolus, he continued to require nearly twice the maintenance fluid that is expected for his age and weight. At 6 hours post initiation of anakinra and intravenous immunoglobulin, the next few hours showed continuously decreasing requirement of fluid as assessed by our clinical status, by point of care ultrasound and our hemogram trends. The blood gas in the first 12 hours, where it had started at a pH of 7.1 with a significant lactate of 6.6 and a 10 of bicarbonate, by 12 hours, our acidosis had resolved. Over the next 12 hours, if you can see, the fluid requirement significantly has come down. We had stopped colloids by 20 hours into course, and by 23 hours, we had initiated on diuretics as he had gone on to the resorptive phase with the full IVC. If we can take a moment to look at this hemogram trend, at admission, he had significant hemoconcentration of 18.7 gram per deciliter. Every 6 hours is our unit policy to repeat hemogram in a patient as sick as him. And we can see that the hemograms are continuously downtrending to reach a 9.9 gram per deciliter at the end of 24 hours. If you want to look at the overall picture for the first 4 days, we can see that the blue line is the input. We started out with 8.6 ml per kg per hour of input, which had included our boluses, including transfusion. Over the next 24 to 48 hours, it had halved, and it subsequently came down to 1.6 ml per kg per hour. This is the point at 6 hours at which we had initiated our anakinra and intravenous immunoglobulin. By 24 hours, we were already on Lasix and we were off colloids. He was receiving only 2 ml per kg per hour of crystalloids. He had required blood transfusion during the 2nd and 3rd day of admission due to line side bleeding, which we controlled locally and managed with PRBC transfusion. To put his overall course into a single slide, our major issues for him were hyperferritinemia, which resolved over the next few days, acute liver dysfunction, which did take quite some time to come down, but he did recover. Bleeding diathesis was managed with local control and transfusion. His cultures were negative by 48 hours into stay, after which we stopped our antibiotics. But the most significant of all is the fluid requirement, which had significantly come down by 24 hours and he had gone into resorptive phase, and there was rapid cessation of leak and progression to recovery. This was his X-ray on day 1 of admission. Within 48 hours, you can see how nicely the pleural effusion is resolving, and by day 5, it was very minimal. To look at the LFT trends, the blue ones represent our SGOTs. You can see uptrending SGOTs till day 3 of admission, at which point he was already on day 3 of anakinra and he has completed his IVIG course. And it started coming down by day 4 to 433 units by day 6. The ALT, which was 230 at admission, was significantly going up to 350 by day 3 and started coming down. Similarly, our albumin had reached a peak of 0.8 by day 3 and started coming down to a minimum of 0.5 by day 6. And our albumin showed persistently uptrend. These are our ferritin and LDH values in relation to our immunomodulation. As you can see, we started out with a ferritin of 36,352 and a LDH value of 2,210 on day 1. We repeated 48 hours later, and we can see that every 48 hours, there is halving of the ferritin levels. And LDH also shows continuous downtrending. He was completely off fluids by day 4 and he was discharged by day 7, and he is on follow-up with us and is doing good.
What was remarkable for us in this particular illness was that when children present with this kind of picture at the beginning, with hemoglobin of 18, severe acidosis, lactate being high, base deficit being around -20, releasing around 10 ml per kg per hour of fluids. These tend to have a long protracted course. They kind of leak for around 48 hours. And in the process, they land up developing liver dysfunction, hepatobiliary dysfunction, and the course becomes extremely complicated. And what we found fascinating was the way the leaking kind of stopped in the period of next 6 to 8 hours, and the way over 24 hours the child ended up in reabsorption phase. He went into a phase where there's a fluid reabsorption, and then in fact we had to start him on Lasix. So that was quite an interesting observation we had with this particular child when we used anakinra. So I can also see in a lot of chat box saying that anakinra is not easily available. In fact, we import anakinra, and it's not a very easily available drug. So my question is, I know Dr. Kishan Chuk did say that he would prefer to give dexamethasone because that's much more easily available. Again, question to Dr. Randy: in case if you don't have an anakinra as an option, what would you consider? And also a second question is, IVIG particularly is expensive. And unfortunately, in our country where everyone pays from their pocket, cost becomes a very sensitive factor. And especially if a patient is big in size, and IVIG expense can be enormous. And the first day expense of giving both IVIG and probably anakinra in combination tends to make it extremely expensive. And that makes it really difficult in terms of initiating therapy. So in such kind of situations, do you think, if at all we have an access to anakinra, can you just use anakinra alone? And also I would want you to comment on, if you use anakinra, do you think the way we used in terms of over 4 to 5 was appropriate, or would you do it anything different? Do you win it, or do you stop suddenly?
Yeah, so I would just say anecdotally, again, not related at all to dengue, but in other cytokine storms, I have personally not found IVIG that beneficial. I don't find it harmful. So as long as you get, blood set aside prior to giving it, if you need other studies down the road, I don't see any downside to it. But it is, other than it being expensive, like you said. The only thing I would do differently with anakinra, and it may work on its own, I think, by the way, you should report this case. It's pretty fascinating because I haven't found anything in the literature on using anakinra for dengue, really. But you may be able to get away with it on your own. I personally go high and drop low. So I don't like to chase my tail. And because it's got such a ginormous therapeutic window, like, for example, when they used it in the sepsis trial that was reported earlier, they were using 2 mg per kilo per hour in people who were septic and in the ICU, right? So you can get away. So I tend to start at 10 mg per kilogram per day. Again, expense may limit that. And you got away with whatever dose you gave here. And then in terms of stopping it, one of the first patients, the RAB27A that Claudia presented, I left that patient on it for 1.5 years because I was terrified to stop it. She had a mutation, but it turns out I probably could have stopped it much sooner. But I find it a very safe drug, and if you can get around the cost issue, it's the last drug I tend to taper. But if you need to taper them, it might make sense, particularly if you start high, to go to lower doses and maybe even go to every other day dosing or something like that to make sure they don't rebound.
Yeah, thank you so much. Because we kind of started using anakinra alone of late, and at a much higher dose, like you mentioned, around 10 mg per kg per day. This was our initial few patients. Because of the difficulty in knowing whether there is sepsis or no sepsis, we started using this combination, and we couldn't find a literature where anakinra was used alone. So it was nice to hear that you to prescribe the view that anakinra can be used alone. So I'll ask Dr. Kishan Chuk if he has any comments on this, and what are your views, Dr. Chuk?
Well, I have no experience with anakinra, but I would still say that steroids would be my first choice, and I would agree that IVIG probably is not as effective, or is not my first choice in such situations. The second point, well, devil's point is, this child responded too soon, too fast. Yeah. His fluid requirement just within hours was so little, and it's almost unbelievable.
Absolutely.
So what I'm trying to bring out is, in spite of all those high ferritins and all those things, was any immunomodulation actually required, or would the child would have done the same if we are not using immunomodulation? I know it's a very provocative statement I'm making. Let's have comments.
Yeah, I mean, it's a very good question. And I think one of the things, and there's one of the things I will talk tomorrow in my talk about what to do, because there is this whole, I'm sure a lot of us do have an experience where we see the ferritin levels do settle down on its own, provided we do an appropriate fluid therapy. And that there is a certain group of patients who just with the supportive therapy, everything does get better. But really figuring out who are those patients who do not get better at all, I think that's the most important question for us to answer in terms of using immunomodulation therapy. And that is one thing I think I will be talking tomorrow in that talk, because that is something we try to look in our own data and looking at all the international data where ferritin about 10,000 and fast raising and in the presence of organ dysfunction. I mean, this case we particularly want to present because even we were stunned looking at the way the child actually responded, because that kind of acidosis, base deficit, needing fluids, needing blood initially, we're quite surprised to see it actually work, because we're also not really hopeful that it might work that well. But this was one of the cases who had classical leaking. It kind of responded quite well. But absolutely a fair point, and it's a difficult question. But that is something we kind of try to look into our own data for the last 1 or 2 years and figure out who don't do well, because this is something we started doing this year, and hopefully we'll be able to present a little bit of it tomorrow.
Well, just one more little, sorry. Yes, I would have also started steroids, the one that I use in such a situation. But suppose this report that you have said 30,000, 34,000 something comes when the child has come from outside and carries this report, and then I would probably repeat it. And sure enough, there will be a gap of let's say 4-6 hours at least. And if I already see a downward trend, I would probably hold on and look at the response to the initial fluid therapy. If that alone is sufficient as it appeared in this patient, if not sufficient, at least somewhat supportive, then hold on and not use immunomodulation.
Yeah,
I would give a slightly different perspective in that I have seen anakinra, again, a drug that I feel pretty comfortable using in a lot of situations because of its safety profile, make changes really rapidly. Like a kid who's sick as heck, who the next day looks like they probably not need to be in the ICU anymore. And so it's anecdotal, but I've definitely seen it. And we also know that the earlier you treat, the better your outcomes are going to be. So maybe waiting 12 hours or something, okay, maybe, but I tend not to wait, because the data is getting clearer on the aspect that the sooner you treat the cytokine storm, and in my opinion, if you get a fever and a ferritin over 10,000, there are very few things outside of a cytokine storm that are going to do that, unless you have chronic liver disease or get multiple blood transfusions, but you're going to know that already. So I would push to giving it earlier, and again, if you don't need it, you can always stop it. It's got a half-life of like 4 to 6 hours, so even if you think it's dangerous, it's gone before you know it.
Yeah, so absolutely, Dr. Randikran. I think that's a very important point, and this is what we also observed, and hopefully we'll bring that up in tomorrow's presentation, is that dengue is a disease which changes in hours. It doesn't give you enough time over 6 to 8 hours. And moment the ferritin crosses beyond a lakh, and what we found out is no matter what immunomodulation you give, it is to limit the amount of damage. It does not do a great job compared to patients where you start a bit early and prevent that kind of progression. So that is what we also observed, that I think the sweet spot is not starting it too early where the patient would have improved anyway, and starting it so late where any kind of immunomodulation does not make a difference. So that's probably the sweet spot probably for most of the immunomodulations in this particular condition. And here I think, like Dr. Kishanchuk said, for us the most important point, what we consider is there an evidence of progression of illness, or it's just the elevated ferritin which might. So if we get a ferritin level and patient is hemodynamic stable, doing well, we might not go very aggressive with immunomodulation. We probably wait for the next value. But in this patient, he didn't carry a ferritin value. This was the ferritin value sent in our unit, and we got it within 6 hours. But the ferritin was important in the clinical context of child worsening, needing around 10 ml per kg per hour of fluids, of which one was blood. So that was what was really important for us to take up a decision of using immunomodulation in this context. So we'll go through next case. Again, it's a bit more interesting and a bit more challenging, and we have used a different drug combination because of practical difficulties. So I'll ask Dr. Pavitra to go to the next case, and we'll discuss some of these concepts again during that case presentation.
Sure, sir. Let's move on. This is patient V, a 14-year-old adolescent boy who came to us with the above pre-referral course. On day 1, he had fever, high grade, for which he was investigated at a local hospital and was found to have a NS1 dengue positive, and CRP was 19, whereas their cutoff was less than 6. And hemogram looked okay at that point. By day 2, the fever persisted and he had new onset vomiting and loose stools multiple episodes, for which he was admitted as an inpatient there. And he was noticed to have shock requiring multiple fluid boluses. And labs at this point showed leukopenia with a downward trending platelet. On day 3, although developing altered sensorium, his shock was persistent, requiring fluid boluses and also blood products, and his oxygen requirement had gone up. Labs had shown a drop in platelets to 57,000, and in combination with all the above factors, he was referred to our unit for further management. On arrival to ER, he was found to be in altered sensorium, he was in shock, he was hypoglycemic, and he was requiring oxygen. These are our initial set of labs, which show a metabolic acidosis, thrombocytopenia, CRP of 66, and organ dysfunction in the form of mild left ventricular dysfunction. He already had renal dysfunction on arrival with a urea of 77 and creat of 1.3. And his liver enzymes were already deranged with 1,200 of OTs and 383 of PTs with coagulopathy and bilirubin of 1.5. Urine had albuminuria. So initially, he was, our first differential diagnosis was MIS-C at this point in time, given the multi-organ involvement with left ventricular dysfunction and elevated CRP, for which we had initiated him on pulse steroids of 10 mg per kg with antibiotic cover, because sepsis was also one of the close differentials. He was managed conservatively for his renal dysfunction. Ultrasound showed bright and bulky kidneys and evidence of leaking. By 6 hours into our course, we received the above lab report, which showed a hyperferritinemia, 31,000. LDH was elevated. NS1 was positive in dengue, and COVID serology was negative.
Again, I think this is one more difficult situation. I think most of us would agree the intensives across the country we come across because of the current pandemic. The way the children manifest, and many of the dengue who have presented also are quite atypical. And the way this child presented with fever, having more of a GI complaints, having LV dysfunction presentation, the CRP being high, it kind of thought we're probably dealing with MISC, and child received methylprednisolone. But the subsequent lab, looking at that ferritin levels, was disproportionately being high, because that's not the value normally we see with MSC, COVID serology being negative, and dengue report coming positive. It kind of made us a possibility of thinking about hyperferritinemia sepsis. So again, I just want to know your thoughts about how would you approach this kind of children, and also the great difficulty here is the other differential diagnosis obviously is a bacterial sepsis, because having a GI complaint, probably it's a gut-associated sepsis, and then you develop hepatobiliary dysfunction as a part of that illness. So sepsis at one end with the bacterial infection, MIS-C being another differential diagnosis, another thing being a manifestation of dengue. So in these kind of clinical difficulties, what we face as clinicians, how would you approach immunomodulation? Would you do immunomodulation at all, or you would just do antibiotics and wait and see how things go? Do you wait for this ferritin to settle down on its own with antibiotics, or you do think that this is about 10,000, this child is febrile, it's symptomatic, definitely needs immunomodulation?
I mean, I'd say the same thing. This is a kid who's got a high CRP and a low SED rate, so he's probably got a very low fibrinogen. And again, you got a ferritin over 10,000 in the setting of a hospitalized febrile patient. You got a cytokine storm until proven otherwise. And so again, I'm comfortable starting anakinra at this point. Of course, start broad spectrum antibiotics. I mean, that's kind of a no-brainer. But yeah, I don't see the downside, and I see a lot of potential upside.
Dr. Chug,
Okay.
any comments?
Yes, I think if you get a patient of this type, my response as an intensivist would be that this child could have all the three things, that any one of the three things that you have said, or maybe more than three, more than one, whether it is COVID-related MIC, whether it is dengue alone, or whether it is a bacterial sepsis, or probably two of these or three of these. Everything is possible. Yeah. So as an intensivist, what we would do is treat. We can go on. We have hours and days, hopefully, to come to a conclusion as to what exactly it is, and then we can modify our treatment and focus it more towards the cause that we really conclude. But till then, we would treat as if it's any one of them. So that means the child would receive steroids, child would receive the IV fluids that we would give for dengue and the shock syndrome and the supportive treatment, and also broad spectrum antibiotics as we would choose in another bacterial sepsis.
Thank you so much. So yeah, absolutely. So thank you so much for those wonderful comments. Dr. Pavitra, do you want to go ahead?
Yes, please, sir. So in the next 24 hours, what we saw was a clinical deterioration. His oxygen requirement had gone up. His sensorium had dipped by more than 2 from the baseline at which he had presented. He had hemodynamic instability with worsening of left ventricular function, and his vasopressin requiring adrenaline, noradrenaline, and vasopressin. His organ dysfunction had worsened. Ureas had gone up to 127 and creat had gone up to 1.9, and CRP had shot up to 171. So at this point, we tubed him, placed him on mechanical ventilation. But as to the next course of action, so whether this clinical deterioration was secondary to untreated fulminant sepsis, or whether it is an evolving hyperinflammatory state which is causing his organ dysfunction. So our choice of immunomodulation at this point was intravenous immunoglobulin because it looked like a more safer option for us. He was also initiated on dialysis, and second day of pulse methylprednisolone was continued. Next 24 hours, he did not deteriorate, but he really did not improve either. His left ventricular dysfunction persisted. He continued to require vasopressor support, and blood culture at this point had grown Enterobacter cloacae. And this was a sensitive organism which should have responded to our antibiotic of choice. Our ferritins, which were repeated 48 hours later, showed it was 11,942, which had come down from 30,000. And LDH also was showing a downward trend. We continued the same line of management, and we de-escalated antibiotics to levofloxacin, which the organism was sensitive to. He was on third day of pulse methylprednisolone at this point. But the next day, again, there was a dip in his clinical status. He had new onset bleed from the tonsils, from the posterior nares. His platelet had dropped significantly to 16,000, which was the lowest point, to 219. His LDH again had gone up by 4,200. His AST ALTs were sort of the same, but his bilirubins had significantly gone up. So in this background of new onset bleeding, upgoing CRPs, upgoing LDH, and worsening hepatobiliary function, despite being on sensitive antibiotics, this pointed strongly towards a more hyperinflammatory state rather than an infection. So this is our patient who's on mechanical ventilation. You can see the HT catheter. He's undergoing dialysis. We have an epistaxis catheter in place to achieve local control, which is our first step in case of any patient who's having a bleeding diathesis.
Yeah, so the important question for us in this particular context, especially as you can see on the day 2, the child seemed to have worsened hemodynamically. You have gone up on vasopressor support, echo shows worsening LV dysfunction, and your CRP is not coming down and it's going up. So the greatest difficulty for us as clinicians is our culture reports don't come up till second day. Sometimes it goes up till 3 days. And when a patient deteriorates this way, the difficulty is for us to know whether this deterioration is because of worsening HLH, or is it because we have not treated the infection appropriately. So in this context, that's the reason we added IVIG. I just want to know your thoughts about how would you make that kind of differentiation clinically at the bedside, and also essentially about that.
It's hard to know when you have infections going on. But I still say as you were surmising, I think this is a hyperinflammatory state on top of all this. And so it's also, I like to follow the SED rate too, because it may continue to drop. And the fibrinogen I find valuable in that sense too. And or other markers of just bacterial sepsis that we heard about some earlier talks in the last couple of days. But you got to treat both if they're both occurring. So you know, the follow-up blood cultures will hopefully give you an answer of what's going on.
Yeah, I mean, Dr. Joe Carcillo mentioned yesterday about doing procalcitonin, which he feels kind of differentiates inflammation versus bacterial sepsis. But our experience in our unit has been, I mean, we have seen patients, a lot of MIS-C, who have procalcitonin going up till 200, and it's above 100, extremely high, and just comes down with immunomodulation therapy. It just comes down with the steroid therapy to normal in a couple of days' time without any antibiotic cover. We have not personally in our clinical practice found it to be particularly marker of bacterial sepsis. I just want to know your thought on that. I mean, what you consider would the role of procalcitonin be? And after that, I'll ask Dr. Chuk what he thinks his practice would be.
Yeah, I mean, we don't always get the procalcitonin, but when it's there, you know, we scratch our heads too. I don't think it's as clear cut as bacteria versus no bacteria. So yeah, it's I think the other thing I would say, and this is again a cost issue in part, is the more we study, the more we know in our patients, the better idea we're going to have down the road. But so I like it in that sense too, because we're all going to learn something from this. Are they valuable? Are they not valuable? And what settings are they valuable?
Dr. Chug, your comments?
Yeah, can you hear me?
Yes, we can hear you, sir.
Okay. So the points here are whether it's a hyperimmune status that is driving the difficulties that we are having in treating this patient, or is it sepsis, or is it a combination of the two?
Absolutely.
And we have relied on, let's say, CRP, blood culture, and if we had procalcitonin, and maybe blood counts and such markers. Like first, I'll try and say something about procalcitonin. You see, every time we are doing these tests in the ICU, I'd say to all my colleagues that if one was going to give us good answer, we wouldn't have been doing 4, 5, 6, 7 of them. So obviously, each one of them has its limitations. And as you said, we saw fantastically, unbelievably high values of procalcitonin. It was clear-cut viral infection or MISC or something else.
Yeah.
So any single thing, when it is introduced, I think we just take it to the sky and then just let it float around. Half of them or maybe most of them fall either to the earth or even deeper. But this one is floating around. Okay. So the second point was that this child's CRP was going up, which again is indicator, yes, possibly. Again, I said possibly that some the sepsis is going on. Third point that yesterday Dr. Carcillo also pointed out in a case discussion of one of the cases, when I see a bilirubin rising with the enzymes not rising that very fast, I would think sepsis is what is driving it rather than direct damage to the cells by other things. Cholestasis is a component there. So all things put together, I would probably think that de-escalation of antibiotics just because Enterobacter cloacae was sensitive to levofloxacin may not be our best thing to do. We do talk about a lot of things about antibiotic stewardship and de-escalating and so on. I fully agree with you. But then here, I think given the circumstances that I was in, I wouldn't have de-escalated.
Thank you so much for those useful comments. Go ahead, Dr. Pavitra.
So we attained source control of the bleeding, and at this point, we initiated him on anakinra, and we downgraded the methylprednisolone to 2 mg per kg maintenance, since he had already received 3 days of pulse dose. Over the next 3 days, neurologically, his sensorium was progressively improving. His hemodynamic status improved. We were able to wean off his vasopressor support, and his LV function improved. From the point where we had initiated dialysis, where he required a daily sled and scuff, we were able to reduce it to alternate day scuff, and he was off sled and scuff by day 7-8. and his liver function tests recovered, but they were lagging behind. His bleeding controlled over the next 72 hours, and anakinra was continued for next 4 days. He was extubated on day 8 of admission, and he had some perioral ulcers and blisters, which was herpes labialis. For the same for 14 days, and we continued levofloxacin for total 10 days of duration.
Yeah, so again, the difficulty, like we were just mentioning, is what was not clear to us is whether we should use anakinra or not at this point in time and just wait for the antibiotics to work. So I just want to know a comment on that. And I think we just discussed a little bit about that already. One of the things, what many people of in intensive community worry is the possibility of infection. And also particularly in dengue, a lot of us, a lot of other units whom I know very closely have been using pulse dose steroids as a drug of choice, like what we've done in this particular patient. And what they have noted is the difficulties with secondary infections. And one of the reasons why we moved away, like using steroids as a first drug of choice in our unit, like what we did in the first case where we wanted to use more of anakinra, is mainly because when we looked into our data, almost 90% of them, especially on the CRPs, on the elevated side, they almost always have secondary bacterial sepsis. And unfortunately, it appears that many of them are gut translocation, many of them are multi-drug resistant, and becomes incredibly hard to know what antibiotic to use, because even a commonly used antibiotic, they seem to be resistant. So for that reason, we kind of avoid using steroids, and we've had children who have not been to any hospital just come to hospital directly, not been treated anywhere else, but the first blood culture grows Acinetobacter in them. So that kind of difficulty, because we've kind of avoided using steroids as a first drug of choice. And I see a lot of questions here in the chat box asking why can't you use DEXA? And Dr. Chugh also shared about his views about using DEXA. But the difficulty, what we noticed with using steroids is that many times you have untreated bacterial sepsis whose sensitive pattern we don't know, and they turn out to be multi-drug resistant, and the antibiotics would not have covered. Meanwhile, they would have gone on steroids for 2 days till the culture report comes, and we have lost few patients in that process. So that's the reason we kind of moved away from that practice. But nonetheless, I just want to ask Dr. Andy Crown, what we've noticed, like in this patient who developed a herpes infection, and this is the second patient on anakinra we saw developing herpes infection. We just want to know, is this kind of viral reactivation common on immunomodulation therapy? If at all you see any secondary infection, is it, if you were to take steroid alone, steroid plus anakinra and anakinra alone, which of these immunomodulation therapies have a higher incidence of infection? What kind of infections do we see? Because some of my colleagues have reported that they've even seen brain abscesses because of staph. Some of them have seen Candida infection. Some of them have seen Aspergillus infection. This is mainly when they use steroid as their main immunomodulation therapy as a go during dengue. So I wanted to know your thoughts, which could be the safer in terms of developing this kind of secondary infections. And do you have a policy of monitoring them and actually looking for this kind of infections? Because one of the things I think what Joe Carcillo also presented yesterday was about how DNA viruses can drive the ferritin up, and probably DNA viral activation can happen during the therapy. So your thoughts, Dr. Andy?
Yeah, so my guess is for this child, the herpes was related more to the steroids than the anakinra. So I haven't seen, I've used a lot of anakinra, as you might imagine, and I haven't seen herpes from that. That's not to say that it may not contribute, but I think steroids are much more likely to contribute. A lot of people don't use anakinra in part because they don't really know what it is and are not familiar with it, haven't used it before, but it really is, it's something your own body makes. And you're giving it more to balance out IL-1, and not that IL-1, you know, doesn't have an important role, but it's pleiotropic. It also has a lot of redundancy with other cytokines. So I would say that IL-1 alone is going to be safer in terms of potential secondary infections. That's not the only thing I've really seen is occasional liver enzyme bumps, and so people are afraid to use it when the liver enzymes are high, but often the liver enzymes are high for another reason, including the potential cytokine storm, and the IL-1 actually will lower it. But I have seen it raise it, and stopping it has improved that. But those were transient. So I don't see a lot of downside in terms of infections. The other thing I will say to kind of counter that is, you know, I had a couple children a couple years ago who had a really bad H1N1 influenza, who were as sick as anybody I've seen in the ICU. ECMO, you know, they were losing toes and fingers, And they got somewhat better on anakinra, but it wasn't enough. And so I give anakinra, I give it early, and then I give it about 48 to 72 hours. And if it's not enough, then steroids in those two patients saved their lives, very high dose steroids. So if that's what you're up against, and you know it's an inflammatory problem, you can't just say, okay, well, I don't want to get a secondary infection because they're going to die. And both those children survived. One of them lost some digits, much less than I expected, actually. But steroids saved their lives. So I'm not trying to say don't use steroids, but early on, and that's when you're going to get the most bang for your buck in treating a hyperinflammatory state, I start with anakinra. And I think you don't have a high risk of secondary infections with that alone. But I will say also that the longer you're in the ICU, the longer you're sick, whatever's going on, and longer you're getting broad spectrum antibiotics to set you up for something else, that's going to put you at increased risk of infection too. So the sooner you can make kids and adults better with these conditions, the less likely you're going to have those problems.
Thank you so much, Dr. And I think you bring up a very important point. I think there is one question also in the comment box saying that if anakinra does not work, what do you do? So you answered that quite well, saying that you go for high dose anakinra, that doesn't work, you go for high dose steroids, and then you understand and accept the risk of secondary infections because the other choice is death. So getting secondary infections is probably more better than actually dying. So you look for infections and then actively treat those infections as they appear. So Dr. Chugh, any comments on you on this and your experience on using steroids and secondary infections in dengue?
Well, yes, it's a difficult situation many times that we face. With these infections coming along in situations where infection was not our primary diagnosis, whether secondary or reactivation or translocation or whatever you want to call them. So everything put together, we have to treat the patient as best as we can today and at that point of time. Whatever information we have, we make our choices accordingly. So while the discussion and the investigation into the cause can continue, in the initial phase, as I said earlier, we will treat for anything and everything that we are thinking of. And kind of as soon as we have evidence of one not being there and the other being more important, we'll tailor our treatment accordingly. That would be my general statement.
Yeah, I mean, that's an excellent and great comment. And I think embodies the philosophy of how we practice intensive care. So you start broadly, cover your wider possibilities, and then you narrow down over time once you get more and more information. Trying to be very specific and narrow at the beginning, you might land up in more trouble. So be more broader in your approach to start with, just the way we start antibiotics. Start broad spectrum antibiotics, then narrow down over time. So thank you very much, Dr. Chugh, for your comments. So with that, we'll just move ahead. I think she has a couple more slides and we'll just wind up this case discussion. Go ahead, Dr. Pavitra.
Thank you, sir. So this is our patient. He's on mechanical ventilation. He has epistaxis catheter in situ and he is undergoing dialysis. He's on invasive BP monitoring. And we continuously monitored his inputs, outputs, his lab trends, and transcranial Dopplers to look at what is going on. So I just want to take a moment to discuss about the organ recovery post-targeted immunomodulation. So about his platelets and CRP. As we can see, in the first 4 days, the CRP has persistently gone up to reach a maximum of 219 by day 4, and the platelets have persistently dropped to reach a minimum of 16,000. At this time, he had already received 3 10 mg per kilos of methylprednisolone and IVIG on day 2. At this point, we had initiated him on anakinra and continued with low-dose steroids, following which we can notice a sharp drop in CRPs to 68 by day 5. And it was persistently in the downwarding trend. And platelet counts had started recovering by day 5, and it had recovered well to reach well above 1 lakh by day 10-11 of admission. The bilirubin's trends, as you can see, has reached a maximum of 8.8 by day 6. Day 4 is when we saw this sharp rise in bilirubin to 5.7, at which point he had already received the methylprednisolone and IV immunoglobulin, and he was initiated on anakinra at this point in time. After 3 days, we noticed that the bilirubins have started coming down. These were his ferritin and LDH trends. On day 1, where we started out with the 31,000 ferritin and 4,300 of LDH, by day 3, there was a decrease in ferritin and LDH, but on day 4, where we saw the clinical deterioration, we also noticed that the LDH has gone up from 3,500 to 4,275. Following initiation of anakinra, we see that the ferritins are persistently downgoing to reach a minimum of 339 during later on. And LDH also showed a persistent downward trend. These are his enzymes, AST and ALT. And the renal parameters also improved. By day 8, he was off dialysis and his native urine output had picked up, and he is currently off dialysis and doing well. He was discharged by day 12 of admission, and on follow-up, he has normal renal function, liver function test, and he does not have any morbidity. So thank you for this opportunity. I thank Dr. Rakshay for giving me this opportunity. And I would like to acknowledge my co-fellows, Dr. Sandeep, Dr. Vishal, and Madhumitra for supporting me in preparing this presentation, and our unit nurses for meticulously documenting each are the vital trends, the inputs and outputs, and labs without which the presentation would not have been possible. Thank you.
Thank you so much, Pavitra. And I think before we wind up this case, final comments from Dr. Randy Crown and Dr. Kishan Chuk.
Yeah, I mean, I again would encourage you to try to report your experience with this, because I think it's really important. It's not, you know, anakinra in isolation, but I think you helped these children immensely by choosing that therapy. I will say that, you know, there are some markers that lag. So often the liver enzymes take a little longer to show improvement. So before I give up on anakinra or other drugs, the ones that seem to trend the quickest are the serum ferritin, the C-reactive protein, and the platelet count. The liver enzymes will sometimes lag, but they're also a good marker that you're hopefully going in the right direction. The other thing I'll say is that for cytokine storms in general is that by the time you get to poor renal function, you've got pretty bad systemic disease. Or multi-organ failure or SEERS or whatever you want to call it in the intensive care unit. And so it's not really a typical feature of a cytokine storm in general. But you know, if you're sick enough, your kidneys can be sick too. So again, I tend not to wait, you know, and when they show up like that, you have no choice. But I tend not to wait for the kidney to be a problem, but I'm glad his have recovered.
Thank you so much, Dr. Randy Crown. Dr. Chuk, final comments?
Well, on the patient as a whole, what we should probably always be doing is treat whatever exactly we are looking at. And when we're looking at improvements or deterioration, again, take the patient as a whole. There will be some who had a hit, let's say, by the cytokines or the infection or something. And today their SGPTs and creatinines are not too bad. Tomorrow, day after, they may appear worse. Doesn't necessarily mean that they are getting worse in that sense. It may be the hit that occurred, let's say, bad hypotension and bad hypoxemia or something, maybe seen worse on the second day or even the third day sometimes. So whatever you see, treat that accordingly, and not jump to conclusions that your patient is improving or deteriorating just because one single, let's say, the creatinine is worsening while the rest of the things are stabilizing. Well, all that we have to do is support the creatinine in the sense where to start doing RRTs or CRRT or whatever else we want to do. So each organ system needs to be supported. And of course, we keep looking at the possible cause that is driving all this and try to address that alongside.
I think Dr. Joe Carcillo also probably has joined. If he wants to pass any comments, Dr. Joe Carcillo, please feel free to comment. And I think please go ahead, Dr.
In the trial that we just got approved by the FDA to do in the United States, they were pretty adamant that we had to drop our dosing of anakinra if the creatinine clearance was low. So they wouldn't let us do the trial without that. That's not my practice. And I just wondered if Randy could comment. And then I think it would be really nice to have literature like Dr. Pavitra's case report showing that you didn't have to adjust anakinra and you had had good outcomes with renal disease.
Yeah, I mean, I completely agree with Joe on that. I mean, again, it's got a huge therapeutic window. So even if your kidneys aren't functioning quite as well, you have, these drugs are not like any drugs we've ever used before. And particularly this drug, because it's a recombinant human protein that does one thing, and that's block excess interleukin-1 alpha and beta signaling. That's really all it does. And so when you have something that you can 20 times the normal dose, think of other drugs you can do that with. You can't. And so it doesn't make, I mean, I know why they're doing it, it's the FDA or whatever. But if a kid's got renal failure, I don't adjust my dose, because why?
Yeah, I wouldn't either, but that is what the FDA is. So the more data that you can have that shows that it's safely given at higher doses, the more likely the FDA will change its mind.
Yeah, can I just add in here? So we were actually deliberating on the dose of anakinra for this particular child because he went on dialysis. And most of the literature that we could find said dose adjustment needs to be done. So that's why we chose a lower dose in this child, but perhaps that's something we can reconsider in the future.
And I think one of the points which brought over by Dr. Andy Cron is that people have used continuous infusions like 2 mg per kg per hour, which is much more higher dose than standardly given. So when you have such kind of therapeutic window, probably modifying dose for renal failure might not be required. So I agree with Dr. Chugh also. Wonderful comments. Those are wise comments. Never look lab in isolation. Always look in the context of how the patient is, because there are times where the labs have a lag period. Things get worse before they get better, but patient gets better much before than the labs do get. So don't just jump purely because labs have become worse. Treat the patient as a whole, and that's extremely important. And I think no amount of clinical acumen is going to replace, labs can't replace a clinical acumen. So labs are there to support clinical decision making, but I think seeing the patient overall, ensuring that the patient is actually getting better, and like what everyone mentioned, sometimes some of these labs do take time to get better. So we should not rush and treat those. So with that, I'll just wind up.
Rakshesh, just
yes.
One little
yes.
request that I want to make to Randy and to Joe Carcillo.
Yes.
Maybe you should convince these manufacturers of anakinra to support a trial here in India on the role of anakinra in dengue. And I think that would certainly, the confidence that you are showing in them, in the drug, that will certainly increase their sales here, and they would
Absolutely.
more than make up for whatever they've given us as free.
I think, and Randy can say what he knows about it, but I think that it has to do with manufacturing of proteins, which take a lot more than manufacturing drugs. So I think it's also has to do with supply chain issues. But any comments, Randy?
I mean, it took me we've done a couple of clinical trials ourselves. We haven't published them yet. We're getting ready to, but with anakinra and various forms of cytokine storms, including COVID. But it took me a long time with that company. They're not a huge company. They're not Merck. They're not Pfizer, right? And it took me a long time to convince them of this great asset they have with this drug. And so I think, they definitely get it now, and I have good contacts with them. I read a great proposal for a grant a few years back to do exactly this. It wasn't in India, but it was in Southeast Asia, to look at anakinra for dengue, and I gave it a great score because I thought it was a great grant, but it didn't get funded. So I would keep pushing, and I actually have talked to people at SOBI about dengue, because you guys already, 390 million people get infected, and a significant number end up in the hospital every year. It's the biggest cytokine storm we have in terms of numbers. So yeah, I completely agree that a trial needs to be done, and hopefully it's done well, so that we learn something, and that we don't miss something. But yeah, I completely agree.
Maybe we should ask Merck or somebody, some such company, to take over this smaller company, and then they could fund us.
Yeah, that's really, I think, what will have to. I think that's what will have to happen.
Thank you.
It has to go to a larger company.
All right. So thank you so much, and thank you so much, Dr. Joe Carcelo, for joining. And we had a wonderful discussion today. Again, 2 cases were discussed at length, and your insights are very valuable. And a lot of important clinical clues, tips, which have come up out of this case discussion. And we just wanted to present these cases particularly because, to bring up that there is something we can do beyond what we are doing, and that's about using immunomodulation. We'll discuss about a bit that too tomorrow again, sharing our own experience about using immunomodulation dengue. And we have tomorrow the last day left for the conference. A lot of exciting talks are still there, and we're going to have the same pattern, start at 6:30 and end with a case discussion. So looking forward for all your active participation tomorrow, and thank you very much for joining us today. Have a good night.
Thank you.
Thank you.
Pavitra, can you stop sharing?